May her soul rest in peace.
Soul rest in peace.
So we start our.
Dr. Manish, on behalf of Delhi Orthopedic Association, I would like to extend my sincere condolences
Absolutely,
from
all of us.
EC and the
Please convey to him.
Yeah, he is a very senior member of Delhi fraternity and doing a lot of work on spine. So we will miss him, but his absence will be, I think, fully taken care by Dr. Ankur. So I welcome you all, and I welcome Dr. Sudhir Kapoor. I welcome Dr. Shankaracharya. I welcome Dr. Sumit Sural, Dr. Kamran Farooqi, Dr. Abhishek, Dr. Abhay Nani will be joining us, Dr. Anil Jain is joining us. I welcome Dr. Sharath, Professor Lalit Mani, Dr. Dhananjay, Dr. Hitesh Lal, Dr. Vineet Arora, and Dr. Rehan.
Thank you, boss.
And our own, Dr. Shamsul Huda and Dr. Ravi Chauhan. So before, without wasting any time, because last time we had to exceed our time by 3 hours, so we'll go to the first lecture. I'll request Dr. Kamran to speak on the history taking of patient having a patient with spine.
Thank you, Dr. Manish.
Yeah.
Thanks very much for organizing such a wonderful webinar. And I'm sure in these times when we can hardly move out, it will be a great benefit to all the postgraduates. So basically, I will be concentrating, we all know how to take history, but I'll be concentrating on those aspects which we need to keep in mind while taking history, especially in spine patient. So like any other clinical case, first of all, we need to ask about the chief complaint. And in case of a spine, it could be either of a nature of pain. Mostly people complain of pain, or they could have some kind of a neurological deficit, or they might complain of weakness. So we need to ask, first of all, what is their chief complaint? And once that is done, we need to ask about the onset. For example, in a case of fracture, we need to ask, okay, how did the pain start? What their clear-cut history of trauma? Then we need to ask about the duration, especially, when we are suspecting infection, or even, for a mechanical backache, we need to ask.
Dr. Kamran, can you put on slideshow, please?
Is it not on slideshow?
No, it is not. It is not. Yeah, now it is.
But it's not coming on my screen now. Why is that? Just one second. Just 1 second, please. Let me put it on. Okay. Let me see view slideshow.
It will be at the bottom.
Yeah, I know, but
we can see the slides.
It's now there.
We can see the slides.
Yeah, it's okay now. Now it's
okay. It's okay.
Okay. So then we need to ask whether, the course of those complaints, whether it's improving over time or it's worsening over time. That's important, because if it is improving, then we can be a bit assured. But if it's worsening, then we need to investigate the patient further. Then we need to ask about aggravating and relieving factors. Very important. For example, a case of disc prolapse, we need to ask whether, it gets accentuated with cuffing or lifting weight, or it gets relieved with lying down. So we need to ask about these. We need to keep this in mind, that we need to ask about aggravating and relieving factors, as well as the character and distribution. Whether it's a neurological, neurological would follow the distribution of a nerve root, and non-specific pains, patients might complain of pain all over. And the degree of disability also, the perceived disability by the patient, whether they feel they can go to work, whether they are it's so painful that they can't even do daily routine work, where they're bound to bed. So we need to keep all these things in mind. And then we have to concentrate, especially with related to backache, we need to keep the psychosocial history in mind. Many of this patient might have symptoms of depression, and that can accentuate that back pain. So we need to filter them out, especially if we are planning to take them off for surgery. Psychosocial analysis is very, very important, because in patients who have a significant amount of psychosocial problem, if you do surgery, the outcome is not going to be that good. And then we need to, pick up the patients who might be, aiming for a work-related compensation, that they might say that I have backache because of the occupation they have, lifting weight, or maybe even in medical profession, patients who transfer the patients onto the operating table, they might complain of backache, and then they can, claim compensation. So we need to filter out all these things very intelligently and subtly when we are taking the history. Patient's age also is very important when we are taking history. For example, in young group, most of the problems will be related to growth and development. For example, Schwann's disease or ischemic spondylolisthesis or scoliosis. These are all problems of the young age when they are growing and development. And in young adults, disc herniation is very common. So we need to keep in mind, the age of the patient when taking history. And in elderly, we will have problems like a degenerative scoliosis or degenerative stenosis or degenerative listhesis. So these have their symptoms of their own. So we need to keep the patient's age in mind when we are eliciting history. And especially in the elderly, we have to be very careful of metastasis, because that's one of the commonest tumors in the spine, especially in the elderly patients. Multiple myeloma again is very common, and they can also have fractures due to osteoporosis. So age also has a very important bearing, and we need to keep in mind, especially when we are evaluating the pain in the back and the neck. We have to try to, from the history, we have to try to narrow down what is the anatomic structure involved. Then we have to filter out whether disease processes in the spine, is it local or is it systemic, or is it a non-related spine-related problem? For example, something, visceral problem like a retroperitoneal fibrosis, or some tumor in the abdomen, which can be compressing the nerve root and causing, some kind of a radiated pain. So we need to filter these out. And again, so psychosocial factors are important. Is it a non-organic sort of a pain? Is it a somatization of pain? So we have to keep all these things in mind. An important concept that's, pain in the spine can only be caused by structures when are innervated. So the structures we have innervation in the spine are basically muscles, tendons, ligaments, and fascia, bone periosteum, the periosteum surrounding the bone, especially when they are abscess or in tuberculosis. When it gets stretched, it can cause pain. Facet joints can cause pain. They have the innervation from sinovertebral nerves. Disc, although the nucleus pulposus does not have a nerve, innervation, but the annulus has innervation, it can cause pain. Then dura, nerve root, and obviously dorsal root. All these, these are the structures which can cause pain. So we should try to, when eliciting histories, try to narrow down where the patient is coming from. Facet joints by themselves can cause pain, especially, if the patient comes with extension and rotation, or, you can think that maybe if the patient has a mechanical back pain due to osteitis of the facet joint, or, the kind of pain which facet joints cause is by and large local and axial. It's not sometimes, very rarely, it's radiating. The neurologic pain caused by nerve root involvement is more or less dermatomal in pattern. So if you have a patient who complains of pain in a particular distribution of nerve, or to say that it's a dermatomal pattern, then it's more likely to be a neurologic pain rather than, localized to some other structure. We should try to localize which nerve is it. It can be, the pain due to nerve root compression could be either a paresthesia. They can complain of burning or tingling sensation. They can also, complain of hyperalgesia or some kind of ache of analgesia. Or sometimes the patient would just say that I have pain in the distribution of a nerve. A fundamental concept is that we should, when eliciting pain in this, history of pain, we have to try to decipher whether it is a axial pain or a radicular pain. This is absolutely fundamental. So axial pain is something which is predominantly localized to the spine and associated soft tissue. So it's basically central, and it will only be localized to spine, or at the most to the muscles, paraspinal muscles. There absolutely no radiation. And axial pain in spine can arise either from musculotendinous or ligamentous structures. It can also arise from facet joints or vertebral bodies, and also from annulus of the disc. Okay. On the other hand, a radicular pain or radiculopathy arises basically due to compression or ischemia or some kind of pathology in the axonal condition of a nerve root. So that's a kind of pain. Radicular pain is something which is arising because of some problem with the nerve roots. So radicular pain would radiate into a limb along the nerve roots. It could be due to neural compression, most commonly because of disc or some kind of stenosis, osteophytes impinging on the nerve root, or it could also be due to intrinsic pathology in the spinal cord or nerve root, like a nerve root tumor or some kind of pathology in the spinal cord. And myelopathy, we should know the term, and it's because basically because of compression of the spinal cord. A classic example of a radiculopathy because of a disc would be a lower extremity. Patient would complain of a lower extremity pain, which starts in the back or the gluten region and typically radiates into the lower leg along the distribution of a nerve root into the calf or the foot. Back pain may or may not be there. Patient may complain of a shooting or burning pain, but it would typically be in a dermatomal pattern along L5, L4, whichever nerve root, but it should follow the distribution of a nerve root. Patient may complain of paresthesia like tingling, pins, needles, numbness, or sometimes they may complain of muscles. Now, when taking history, the most important things that we should not, especially in a spine patient, is that we should not miss the imminent danger or red flags, which are infection, tumor, fracture, cord-equina syndrome, and progressive neurological deficit. We cannot miss it. So whenever we are taking a history of a spine patient, we should rule out these in the history itself. So when taking a low backache history or a backache history, we will of a new onset pain in patient more than 50 years may, they herald a tumor or malignancy, and in less than 20 years, because in less than 20 years, the incidence of mechanical back pain because of degeneration or degenerative disease is very, very less. So we should be aware. Pain, especially worse at night, because most of the mechanical back pain, it is more with activity and it reduces at night. So be careful if patient complains of pain which is worse at night, either it could be infection or a tumor, but we need to investigate further. Pain worse in supine position. Most of the mechanical back pain would reduce on lying down. Always ask about bladder bowels because that definitely indicates that there's some kind of a major neurologic compromise. Again, ask about saddle anesthesia and a recent weight loss. Again, it points towards either a malignancy or infection. Ask about fever and constitutional symptoms, and definitely ask about malignancy or any kind of immunosuppression. So when we are, eliciting history for cancer, we need to ask about age. Definitely be suspicious if the patient is more than 50 years. I think I'll just quickly rush through. History, always ask about malignancy, any unexplained weight loss, and history of smoking. Again, pain not relieved by rest is typical of cancer. Night pain, if the pain duration is more than 1 month, because most of mechanical back pain or even disc pain, that will subside by 1 month, and they respond to conservative treatment. So failure of conservative treatment, you should think about these things. In case of infection, ask about active or recent infection and history of fever, especially in a country where TB is so endemic. We have to ask about weight loss, appetite loss, night cries, constitutional symptoms, and malaise. Any history, family history of TB, very important. And again, ask about diabetes, drug abuse, and immunosuppression. In case of fracture, it's rather obvious, but do ask about significant trauma. However, in patients who are more than 60 years, there's osteoporosis. So, minor trauma can also cause osteoporotic fractures. So keep that in mind, especially if they're on steroid intake, anything causing osteopenia or osteoporosis, or in patients with diffuse skeletal hyperostosis or ring these have osteoporosis, background osteoporosis. So you should ask about these things, especially if you're suspecting pathological fractures or fragility fractures. In case of cord-equina syndrome, you should always suspect a patient who comes with a new onset of pain and ask about bladder bowel symptoms, any sexual dysfunction, saddle anesthesia, any significant lower leg pain or weakness, and especially if it is bilateral, you should rule out a cord-equina syndrome. In case of myelopathy, ask about paresthesia, especially because fine motor control of the hand is very frequently involved in case of CSM. Ask about instability, gait, in the gait and balance, and also about bladder bowel problems. So, and then finally coming to past medical history, always ask about diabetes, because that can confound your neurological finding. Patient may have a diabetic neuropathy and you might think that it is due to a neural compression. Ask about comorbidities, because if you're going to take up the patient, we need to be aware of hypertension, CAD. Ask about osteoporosis, angst and dish, because these can also impact, the surgical outcome, and especially about vascular claudication, because it has, it will confuse you with spinal stenosis, which is so common in old age groups. So you should be able to, rule out vascular claudication from neurological claudication, and ask about history of TB, because that's so common in our country. And Yeah, and again, in the family history, you have to ask about inflammatory conditions like HLA-B27 positivity because of Angst, and keep these things in mind that they have a familial history. So we should be keeping that in mind to rule out some kind of inflammatory disease. Neuromuscular disease also have a hereditary and genetic predispositions to ask about that, as well as a family history of TB. So I think from history point of view, these are the things that we need to keep in mind, and especially in a case of spine. I think that's by and large we have covered most of the things, but I would like to reiterate that definitely rule out the red flags, which I said: infection, tumor, and bladder bowel syndrome, cardiac syndrome, fracture. These are things we have to rule out on history. Thanks very much. Open to questions.
Yeah, thank you, Dr. Kamran. And his presentation is open to questions now. I have not received till now from the audience. So I think
Can I ask?
Yes, sure.
Yeah, Dr. Kamran, Faruqi, that's very nice presentation. I think that
Your voice is not there.
Dr. Vineet, your voice is not coming.
Voice is not coming.
Vineet sir, your voice is not coming.
Anyone else?
Dr. Kamran,
Can I start my slide share meanwhile?
Yes.
Kamran, you've given a very, very comprehensive disposition of history taking. A couple of points I wanted to add to it. In
Yes,
our
sir.
clinical practice, very often we come across patients with inflammatory back pains, the young patient, middle-aged patients. And in them, I think the history of stiffness, particularly
Yes.
morning stiffness,
Exactly. Morning stiffness, that is very peculiar to inflammatory diseases like Angst or Behcet syndrome and all these inflammatory arthritis. So we have to keep in mind that they will give a classic history of morning stiffness, which improves over time.
yeah,
So
correct.
that is something which is, and sacroiliitis. Yes.
Dr. Faruqi,
Yes,
Faruqi,
Yeah.
I wish to know for the PG students, how will you differentiate between the neurological and vascular claudication on the basis of history?
Yeah, so classically, a patient of neurological claudication will give a history that they have pain while walking, which is similar in vascular. The only thing is that, they will not say vascular claudication will have pain all the time on walking, whereas neurological, when they go uphill or they... Yeah, especially when the spine is flexed, they don't have that much of pain. Whereas vascular claudication, another thing is that especially at night, neurological claudication will not happen if the patient is at rest. Whereas vascular claudication can happen even at rest. When they hang their legs down while they're sitting, even then they can have. And also, rest of the features are on examination. You can see they will complain of cold legs, loss of hair. All those things will be there in vascular claudication. And they also might have history of some kind of vascular disease, maybe cardiac disease, anything which to do with atherosclerosis. They might have, they can give history of atherosclerotic diseases.
But is there any significance of the claudication distance also when you're taking a history? Do you want to know from the patient how much distance he walks and then he has to sit down to take rest before taking another step?
I mean, that will vary on the amount of, the stenotic canal they have. I mean, some patients can walk for 500 meters, some can walk more, some cannot walk even that much. And similarly, amount of, the vascular occlusion they have. But if it is severe, then vascular claudication patients can also have rest pain, especially like sitting or even lying down. Whereas neurological claudication typically comes with some amount of exercise or anything which involves extension of the spine. So they can have a standing, but they will not generally have on lying down or, bending forward.
Dr. Kamran, there is a question from the audience.
Yeah.
How to differentiate between rest pain of inflammatory and tumor cause?
Rest pain of,
inflammatory and tumor origin.
Yeah, I mean, patients of inflammatory arthritis generally will have a low back pain. It begins from sacroiliitis or involvement of sacroiliac joints, and it's more in the morning. They will more complain of stiffness. Patients, and it generally improves, as the patient carries on the activities, it improves with time. Whereas patients with tumor pain, it hardly, it's more or less persistent and it only worsens. And especially when they're lying down and even at night, they can have a lot of pain when the muscle spasm is less. They can have, in fact, more pain because the muscles which are protecting and acting as analgesia for to some extent, that is unmasked when they are at rest. So supine, when they are supine lying down at night, they can have a lot of pain. I mean, that is one differentiating feature. And also, patients with arthritis, they can have involvement of other joints. It will not be just the spine. They can have, for example, in rheumatoid, they can have involvement of other joints, or they can have bladder ball symptoms. So isolated inflammatory arthritis, is rare.
Any other question for Dr. Kamran from the panelist?
I have it. Can I ask one question?
Yes,
Yeah,
yes,
sure.
Hitesh, yes.
Yeah, it was a nice presentation, Dr. Kamran. The
Thank
purpose
you,
of
Hitesh.
history in spine cases that the PG should bring a highlight the differences between extramedullary and intramedullary compression. So you can tell the PGs what in history they should take to differentiate between extramedullary and intramedullary compression.
Actually, just 1 second. While others. So extramedullary compression will classically, localize to a nerve root distribution. It will be more classical to have it, and then again, depending on, localized to a nerve root in case of extramedullary. However, if it is an intramedullary compression, it will not necessarily be localized to a single nerve root. Multiple involvement with there, as well as, if depending on the level, you can have upper motor neuron signs as well as lower motor neuron signs in case of intramedullary compressions. That is arising from, tumors arising inside the dura mater, extramedullary intradural, or intramedullary intradural. So they can have a mixed picture. Whereas let's say a classical extramedullary compression, like a nerve root compression, or let's say extradural compression because of a ligament, let's say ligamentum flavum hypertrophy. All these will give the classic pictures of our upper motor neuron signs with involvement, depending on whether it's a cord level or a corda-equina level or nerve root level. So in a mixed intramedullary, let's say intradural extramedullary, or intramedullary intradural, you will have a mixed picture. We can have upper motor neuron also and lower motor neuron also, and multiple root involvement. Depending on whatever tracts are involved or whatever roots are involved, patient will give a history pertaining to all those things. Whereas in case of a classic, extradural compression, it will be more localized and more along the distribution of nerve root, more dermatomolan pattern.
Okay,
Actually, I didn't cover that because it's not that much in history, or more on examination.
Okay, I welcome
Well,
Dr.
can I just add on to that?
Yes.
Yeah, I think for the postgraduate, it's also important to know that usually the intradural pathologies, whether intramedullary or extramedullary, have bladder and bowel as an earlier symptom presentation compared to the extradural.
Okay, and I welcome Dr. Professor Anil Jain, who has just joined in. So, any other question? We'll take one more question. Otherwise, we'll go to the
Manish, in nutshell, we can say that intramedullary lesions, they are generally painless with neural deficit. Yes. While extramedullary lesions, they generally have a painful, and depending on the root involvement, the neural or without neural. But generally, they are painful or painless. That's the one. If you say 1 point, then painless neural deficit is generally intramedullary.
Any other question? We can take one more question.
Manish, can I add something?
Yes, sir. Yes, sir.
I think for a postgraduate, the same question. I think this is a very important question. Let us say pain followed by deformity is extradural. Deficit followed by pain is intradural or intramedullary. In a nutshell.
Okay. Sir, I think we'll take questions later on. I request Dr. Sumit Sural to present his PPT on examination of spine. Dr.
Yeah.
Sumit.
Thank you so much, and good evening, everyone. Am I audible? Is it clear?
Yes.
Yeah, fine.
Okay. So after a good history, the student should be able to come to a conclusion whether this patient has got a stable spine or an unstable spine. Is there a neurological deficit, partial or complete? And of course, which part of the spine is involved, cervical, thoracic or lumbar? Depending upon whether the spine is stable or not and deficit or not, the examination should be done whether only in lying down position, because sometimes if it's an unstable, whether neurological progressive neurological deficit can occur, then we would not like to examine the spine either in the standing, sitting, or perform movements, or even examine the gait. So having said that right in the beginning, we start with the general physical examination, and it is important not just for the sake of saying no icterus pallor cyanosis, but pallor could be seen, for example, in a metastatic spine, some blood loss going on because of, let's say, GI malignancy, where there is a history of melena. So in history also, we should try to find out the cause of the primary. Icterus, for example, could be seen where a patient on anti-tubercular therapy could develop icterus. Lymphadenopathy, matted lymph node could be seen in tuberculosis, or Hodgkin's can sometimes present with the spinal involvement. Café-au-lait spots, I'll talk about it later. And just expansion, whether you talk right in the beginning, the general physical, or in the as a part of the measurements, it should be done in the fourth intercostal space to rule out ankylosing spondylitis. Now, a head-to-toe examination, I've made the slide for the postgraduates so that nothing is missed, especially in case of metastasis. If you try to find out what would be the site of the primary, whether on the history or on examination. So if you follow from head to toe, neck, for example, thyroid malignancy, and the history could be a history of hypo or hyperthyroidism, and an examination there could be a mass in the neck. A breast examination, even in the males, one should try to examine the breast, the respiratory system, the abdomen, especially looking for any organomegaly for metastasis, trying to assess for any psoas abscess in tuberculosis, and also examining for the any enlarged size of the kidney or prostate or cervix. Usually we do not examine per vaginal examination, but you can always tell the exam that we have not done it, so that examiner knows that it should have been done. And in the tuberculosis, of course, looking for sites of cold abscesses, and I'll talk about cold abscess in the later slides. So, and the general physical examination, a café-au-lait spot for the postgraduates, can you see the cursor on the slide? Is my cursor visible?
Yes, sir, it is visible.
Oh,
yes, it is. Yes,
so you can see the smooth margins of a café-au-lait spots, like the smooth margins of the beaches of California. So that is in neurofibromatosis, compared to the ragged margins, okay, which is seen in the coast of Maine. Maine is in this part of US near Boston, where it's rocky, the land is rocky, and this is seen in fibrous dysplasia polyostotic. So spine examination, we have to do just like any other region, inspection, palpation, movements, measurements, special tests, and gait. So in the inspection, you should look for telltale signs of spina bifida occulta, the attitude, the deformities, cold abscess, and muscle spasms, of which I'll talk a little bit in more detail in the subsequent slides. However, I would like to close these matter here, especially looking for scars and sinuses, whether they're active or healed, looking for pressure sores, wet sores, and what grade of pressure sores it is. And often the candidate forgets to mention whether the patient has got an indwelling Foley's catheter. So after the inspection, during the inspection, let me go on to the telltale signs of spina bifida occulta. You must look for not only tuft of hair in the lumbar spine, but even it could be in the thoracic or in the cervical spine. So exposure of the back is important. Look for lipomas, look for any dimpling of the skin, and for the attitude in the cervical spine, for example, if it is an active disease of tuberculosis, a child may present with a torticollis or a rust sign, like holding the head and neck, supporting the head with his hands. In the thoracic spine, a spasm in the thoracic spine could give rise to a squaring of shoulders, sort of an attitude like a military attitude. And in the lumbar spine, we have the alderman gait. Because of the spasm in the lumbar spine, the patient is walking like an alderman. Alderman are basically a term used in the US or in Western countries who are the city councillors. So they're walking as if, they're high-heeled. So after inspection, we come to palpation. Of course, always palpation starts with local temperature and then the tenderness. I'll talk about this in the next few slides. And the deformity, kyphosis, scoliosis, horizontal kyphoscoliosis. And I'll talk in details about cold abscess later. So palpation, one should check for direct tenderness by palpating the spinous process. However, it is very important, especially in tuberculosis of the spine, where there's a paradiscal involvement, to give an indirect push on from one side of the spinous process, thereby rotating the spinous process and thereby eliciting pain if the disease is in the anterior part of the spine. And you can see that in this next slide, the same patient with the kyphotic deformity, there was no muscle spasm, but at the time of eliciting the tenderness, a muscle spasm appeared. So this can occur in an active disease of tuberculosis. It's very important for the postgraduate to mark the spinous processes, especially with a good skin marking pen, so that the examiner knows that he has done this exercise. And one can identify the vertebral level either from proximal to distal. From the proximal, the first prominent spinous process T7, known as the vertebra prominence. However, the T1, thoracic 1, is more prominent than C7. So sometimes one can miss the C7 and think that the T1 is the C7. So you have to be careful about it. The landmarks of the scapula, the spinous process at T3 and the inferior angle of scapula at T7 are important. But since scapula is a mobile structure, it's very important that the patient, while examining, should have the limbs by the side and not move. If the upper limb is abducted, then there could be a false leveling because of the movement of the scapula. So the distal part, a very good landmark, is the highest point of the iliac crest, which corresponds to the L4 vertebral body. Regarding the deformity, the postgraduate should be able to tell whether it's a knuckle, the single vertebral involvement, or angular 2 to 3, or rounded. Single vertebral involvement could be seen in a eosinophilic granuloma. Metastasis can have single, angular, or rounded anything. Lymphoma usually occurs in single. A central type of tuberculosis, which is quite rare, can cause knuckle deformity. More commonly, tuberculosis causes 2 to 3 vertebral involvements and angular deformity. Metastasis can also have the same thing. And rounded can be seen in Sherman's disease or a senile kyphosis because of old age. Deformity of scoliosis, one should be able to know whether it's a postural scoliosis and whether it's just a scoliosis or is it a sciatic list, and the scoliosis is structural or it's non-structural. Various causes of structural scoliosis are there, and one very easy method of differentiating is ask the patient to bend forward as if to touch the front of his foot and ankle. So if it's a non-structural scoliosis, then the spine deformity will disappear. If it's a structural scoliosis, the deformity will persist. One can also do this while making the patient lie prone. If it's a young child, very small, then even the child can be lifted by the chin, just like in the Russ sign, that sort of a support. And if it's a non-structural, the spine straightens out. That's only for a very, very young child. For the cold abscesses, very important for the postgraduates to know, in the cervical spine, it can present anywhere in the triangles of the neck. In the thoracic spine, it can go. So what is cold abscess? Cold abscess is basically all the debris from the tubercular spine, which is more common in the paradiscal, as I said before, and all the granulation tissue and the debris and the pus, which tracks down along the lines of least resistance. So it may gravitate down, or it can follow the neurovascular bundle or the interfacial planes. So it can follow the nerve root and go in the paravertebral area. It can follow the intercostal nerve root and go along between the two ribs, till the middle or the anterior axillary fold. It can even follow anteriorly in the anterior chest wall. And a very favorite question to the postgraduates is whether a psoas abscess can be, can occur in a patient with a high, like T5 or T6 tuberculosis. So for that, we have to understand the anatomy. The prevertebral fascia is attached to the T4. So all the abscesses due to a cervical spine tuberculosis is limited to the up to T4 itself, but T4 downwards, the abscess may track, gravitate along the aorta, and through the openings of the diaphragm could go into any of the regions I'm going to talk about. So one by one, along the lateral arcuate ligament, this is the lateral arcuate ligament, it can come along the quadratus lumborum, it can go behind the kidney, it can go from there along the 12th thoracic or the ilioinguinal or iliohypogastric nerve onto the anterior abdominal wall. It can go along the medial lumbocostal arch or medial arcuate ligament to the psoas sheath and go down as a psoas abscess. It can go along the median arcuate ligament, which crosses the aorta, and along the aorta, it can go into the abdomen along any of its branch. So it can go from the internal pudendal artery even up till the ischiorectal fossa. It can follow the superior gluteal artery to the buttocks. I remember 2-3 months back, a patient came to our orthopedics ward referred from surgery because there was an abscess in the buttocks and they had done an IND, and later it turned to be a cold abscess from the spine. So the cold abscess can go along the sheath of the psoas or quadratus lumborum. It can follow the lumbar nerves. It can go up to the femoral and obturator nerve into the thigh. It can go on the back. It can go from the sciatic nerve. Theoretically, it can go even as far as the popliteal fossa or even follow the nerves to the toes, though I have not seen one onto the toe. Intermuscular plane, the Petit's triangle is another favorite question we asked. So this is the psoas abscess. And for the triangles, there are two important triangles for the students to know. One is the superior lumbar triangle, which is bounded by the T12. And then you have the internal oblique here, and then the quadratus lumborum. And for the Petit's triangle is the iliac crest, the latissimus dorsi, and the external oblique. So these two areas from the interfacial planes, a cold abscess may track down and one must look for them during the palpation. So different sites of cold abscesses could be there. Regarding movements, as I mentioned before, you must tell the examiner if the patient has got an unstable spine or a neurological deficit that you have not done the movements and would not like to do the movements. However, in an unstable spine, if it's a cervical spine pathology, if it's a stable spine, then you can do the movements, various movements of the spine, cervical spine, various movements of the lumbar spine. Here, I would like to highlight about the thoracic spine. That in the thoracic spine, the most important movement is the rotation, because the other movements are restricted because of the rib cage, and the rotation, which can be observed by making the patient sit on a stool or a chair and rotating from the right or left, the patient will have pain. So that could give a clue that it's a thoracic spine pathology, like a tuberculosis of the thoracic spine, which is anteriorly paradiscal but creating a pain on movement, rotatory movements. Regarding the measurements, various measurements are there. For the ankylosing spondylitis, to know the excursion of the spine movement, the Shover's test, and the modified Shover's test, various books describe it differently. So basically it is when you draw a line along the limpel of the venous and take up to 10 centimeter proximal or the modified 15 centimeter and ask the patient to bend forwards, there should be an excursion of 5 centimeter during the normal movement of the lumbar spine. Whereas if there is a restriction of the movement, it will be less than 5 centimeters. The other movements, which is very important, especially for recording the progress of a disease of ankylosing spondylitis, could be the chin-brow vertical angle, which normally should be 0 degree, but in a patient with kyphosis, it would be progressive in ankylosing spondylitis. Similarly, a normal person, the occiput should be able to touch the wall behind, but if there is a deformity and progressive, then this wall test would be positive. Head occipital, the occipital wall distance would increase. Similarly, the distance between the tip of the fingers and the floor from the front or from the side could give an assessment of the amount of restriction of the spinal movements, forward or lateral flexion. Regarding the gait, Dr. Kapoor would be talking about gait. However, I'd like to talk a few things here. One is the simian stance. Okay, so the simian stance is seen, simian is ape-like, so that is a forward stance, which is seen in lumbar canal stenosis. And the other thing I would like to talk about is the sciatic list. So usually the disc is, it's not a far lateral disc. Okay, so the axillary presentation of the disc, if it's irritating the nerve root, the patient will turn away so that it gets relaxed. Whereas if it's a shoulder presentation, which is irritating near the shoulder, right? Sorry, I said it the other way around. So if it's an axillary presentation here, the patient will turn on the same side so that the nerve root gets relaxed. If it's a shoulder presentation, then the person will turn the opposite side to relax the nerve root. Special tests are there for the disc prolapse and the SI joints, and quickly I'll go through them. The Lassig's test, also known as the straight leg raising test, is by raising the lower limb one by one. It's important to raise on the side where the neurological symptoms of radicular pain is there. So if you raise the limb on that side, between 30 to 70 degrees, it is positive to show a positive SLR. And this is not the correct way of the Lassig's test, where you flex the hip and knee and then extend. However, some literature do mention about it, but we generally talk about this way. And when we perform the Lassig's test, it's important, it should not be just a back pain, it should be a radiating pain along the nerve root. And the sensitivity of this test is 91, but specificity is better if it's a cross SLR, where the patient may be complaining of pain radiating on one limb, but on raising the opposite limb, there is a pain. So that is seen in a large disc, a central type of disc. Then we have the Bragg's test. So in the SLR test, we just lift the limb, and where the pain has appeared, you can just flex the knee a little. Whereas in the Bragg's test, we dorsiflex at the point where the SLR was positive, you bring down the limb a little and then dorsiflex the ankle. So that would again stretch the nerve root and cause the pain. Then the bowstring stretch test, where after doing the SLR, you bring down the limb a little and then you press on to the lateral popliteal nerve, and that will cause increase in pain. So these are the special nerve root stretch tests in case of PIVD. For the femoral nerve stretch test, you need to keep the patient prone. This is more important for the disc prolapse, which is rarer in the L2-3 and the L3-4. So classically, the SLRT was described for the L5-S1, and this is known as a reverse Lassig's test. Test for SI joint, the various tests, let's look at them one by one. The flexion, abduction, or external rotation of the Patrick's test is by stabilizing the pelvis on one side and doing the flexion, abduction, external rotation. Then we have the Gansland's test, where we flex the opposite side, and the side to be tested, we get the patient to the side of the examination couch and take the limb off the couch and do a hyperextension of the hip. So that would cause a pain at the SI joint. And then some examiners also like to know about the pump handle test, where we take the flex the hip and knee and take it towards the shoulder, and that will cause pain. So I think, yeah, so that's about the presentation. I try to do it in 12 minutes. I hope not exceed much time. Yeah, thank you.
Yeah, thank you, Dr. Sural. There is a question from the audience that what is the difference between SLR test and the Lassig's test, or are both are same?
Yeah, so I did talk about that. So the Lassig's test actually is very interesting. The Lassig's test was not described by Lassig himself. It was a student who had described seeing his teacher, and both of them are actually the same. However, I found in some literature that the performance of the Lassig's test is by this picture which I've shown here, not by raising the limb straight, but for the exam, I think the other examiners are on the panel, they might give their opinion as well. The SLR test and the Lassig's test is the same, where you lift the one limb of the patient where the pain is radiating, keeping the knee straight till the pain is, radiating pain is complained by the patient. and then you can just flex the knee to where the pain disappears. So that is the SLRT or the Lasix test, one and the same.
Okay. Now your presentation is open for questions to the August faculty. So questions for Dr. Sural.
Dr. Sumit Sural, it's a nice
Yes.
presentation. For the sake of peace, just let us know whether you will include the neurological examination in the examination of spine or not.
Yeah.
No.
So,
Dr. Vineet, I will tell.
To save some time, what we have done in this today's presentation, I am restricting myself only to back examination, and Dr. Sudhir Kapoor immediately after this is going to follow with the neurological
Dr. Vineet, we have deliberately divided it. So, so actually it is together, but we have divided it.
This is the chart that one wants to follow.
Agreed. Because I wanted to give a message to the pages that this is also part of that one. At least they should
we actually wanted, to have a very thorough discussion on neurological examination. So we have told Dr. Sudhir Kapoor to do it separately, but otherwise they are together.
Yes, you're right. Thank you very much.
Dr. Manish?
Yes, sir.
Dr. Sural, just can you give little more clarification how to differentiate between a sciatic scoliosis and a structural scoliosis clinically?
Okay, so sciatic scoliosis is not the correct term. Sciatic list is the correct term because it is not it is just a person because of pain and spasm is just tilting the spine. Okay, scoliosis by definition is actually a three-dimensional deformity, right? Where you have the actually rotation of the vertebral bodies, right? So a sciatic's list, that is because of irritation of the nerve root, and if we make the patient lie down, the list will disappear. Whereas in a structural scoliosis, whether you make the patient lie down, prone, or you make the patient bend forward, the structural scoliosis will remain. There may be a component of scoliosis which may have partial structural, partial flexible spine. So if you make the patient bend forward or lie prone, the unstructured part that will disappear and the structured part gets revealed.
So Dr. Shankar, you have any question for Dr. Sural?
No, I think Sumit did a very good job and he explained all the tests and everything. So I think let's get on with the Dr. Kapoor's neurological examination.
No, there is one question from the audience that Dr. Sural, how to check for rotatory tenderness?
Yeah. So you see the tenderness in the spine, as I mentioned earlier, is basically the two types. One is the direct tenderness and the other is the indirect tenderness, right? So the purpose of the direct tenderness is if there is a pathology only in the spinous process, then that will get revealed. However, as you know, in tuberculosis, most of the pathology is in the paradiscal. So the indirect tenderness is checked by this picture. You can see you have to go on one side of the spinous process and with your thumb give a rotatory push to the spinous process. That is the indirect tenderness.
Okay, any other question from the faculty?
One thing I want to say, Manish, just since you asked that, I think Sumit didn't, this is telling about examination of the back. Only thing I think you can add is that you need to also test for the piriformis stretch test is there, localized for the greater trochanter tenderness. So these are small things which may be there, which may put you off from your diagnosis, and sometimes patients can have these things.
Yes.
So that's another thing to remember. But I think he did a very comprehensive assessment.
Because of the time given to me was 12 minutes, so I didn't go into that. Yeah.
Dr. Sumit, one last thing. How will you differentiate between the anterior spinal pain and the posterior spinal pain?
No, you see,
like there are some, but
there is pain is by the history. Okay, pain you cannot differentiate by examination. It is the tenderness that we are talking about.
Yeah, sorry, tenderness.
Yeah,
tenderness.
So that's what I said. So the indirect tenderness. Okay, if a patient does not have a direct tenderness and has an indirect tenderness, it means it's an anterior disease.
So, okay, that you will do the thrusting test, thumping or thrusting will be done just to check that.
Is actually those tests are to be avoided, thumping test, because that is actually a direct tenderness, right? And if not unstable spine, it's not good to do a thumping test.
Right.
Dr. Hitesh, you have a question?
Sumit sir, by that time you can just stop sharing so that
sure.
So that Sumit sir can upload their screen.
Dr. Sudhir, you upload your screen, and Dr. Hitesh has a question. Dr. Hitesh?
Hitesh, sir?
I think his video is off. Any other panelists want to ask anything to Dr. Sural by the time Dr. Sudhir is getting ready?
I think another important thing is to make sure that the hip and the knees and other joints are also all right. So that also is important in
Very
these
important.
examinations.
Very, very important. Yes.
Is my screen visible?
Yeah, sir.
Yes.
For
Sir, you
Manish,
can.
25 minutes.
Yes, sir. 25 minutes.
You can go ahead, sir.
Thank you so much. Well, neurological examination is an equally important part for a spine examination. Without that, you can't come to a final diagnosis. Let us understand if a patient of spine is able to walk and allowed to walk. Both are important. Able to walk and allowed to walk. If the spine is unstable, very tender, don't make the patient walk. If the patient is able to walk, one may find out something about the deficit from the gait itself. I'll show you a few examples. This patient, a patient of old spinal trauma, has got a bilateral foot drop. Once he turns around, you can see the telltale mark of the old spine trauma, showing a low dorsal deformity. So if the patient is able to walk and allowed to walk. Similarly, a patient who has got a cervical myelopathy has got a staggering gait. He walks with a wide base gait. You can see that. And there is a hint of a stagger, particularly when the patient turns around. Please see that. Yes, that's right. Wide base gait, staggering as if trying to catch his balance. Is typical of a cervical myelopathy. Then a gait of a sciatic scoliosis, a very, very guarded gait. We'll give you an example, will give you an indication that probably there is a acute disc prolapse. I'll not go into the details, but again, I'll just repeat, if the patient is able to walk and allowed to walk. Now let us come to neurological examination in particular. At the end, once we have conducted the examination, we should be able to tell what type of deficit it is, upper motor neuron or lower motor neuron, what is the extent of deficit, what is the level of neurological injury, what is the correlation with bony lesion, and whether it is a plane of compression, whether it is extradural, intradural, or intramedullary. We should be able to answer all these questions once we have conducted the examination. But of course, it always follows a particular pattern of going through higher mental function, cranial nerves, motor system, sensory system, bladder and bowel. Well, higher mental functions and cranial nerves are not that important for a PG who's going for an ortho exam, but just make a small note of the thing, whether the patient is well oriented in time, space, and place. Similarly, in the cranial nerves, just observe to look for any cranial deficit. I will not spend any time on this. And let us come to the motor system. The motor system, please understand, I have repeated in my last talk also, a particular sequence is the most important thing. If you follow this sequence, which I am showing it to you, you will not miss any point in the exam. As far as the motor system is concerned, talk about bulk, tone, power, and reflexes in that order. Well, bulk of the muscle, see, feel, and measure. Muscle basing may be very obvious. Feel. Flaccid muscle would be flabby, while a spastic muscle will not be flabby. And finally, to confirm, measure that and record what is the exact amount of muscle basing, particularly if it is asymmetrical and there is a difference between the two limbs. So see, feel, and measure as far as the bulk of muscles is concerned. Well, talking about the next is the tone of the muscles. Please understand the tone of the muscles would be either be, if it is involved, it could be either let me stop the video. It could either be a flaccid paralysis in the case of lower motor neuron paralysis, or it could be a hypertonic paralysis in case of upper motor neuron paralysis. Well, there are two methods to do it. Mostly it is done by log rolling. Log rolling can be done either by rolling over the lower part of the thigh, or better if it is on the shin. That is one method of testing for the amount of tension which is present in the muscles of the lower extremity. Other point is to move the limb to the range of movement and try to assess what is the basic tone of the muscles. Please remember, that the increase in tone could either be a clasp knife type or a cogwheel type, which are two most common types. What we and orthopedic patients, in our orthopedic patients, we deal mostly with the clasp knife rigidity. This is an example of that. Please see the video once again. As the examiner starts flexing the limb, there is as if there is an increase of resistance. The examiner goes on flexing the knee, and at a particular time, the limb simply gives way. Please see it once again. Okay, I'll again repeat that as the examiner flexes the knee, he feels as if the body is offering more resistance. Once he keeps on flexing, at a particular point, the limb gives way, like in a clasp knife. This occurs typical in the patients which we see. See it once again, please. This is important, so I'll spend a moment here. Yes, that's right. These are typical clasp knife rigidity seen in the cases of orthopedic patients. A cogwheel type of rigidity is seen most in extrapyramidal tract lesions. Pyramidal tract lesions, which is not what we see normally. There's an increased resistance, there's an increased tone, then less tone, increased tone like a cogwheel. Well, once we have seen the tone, we must comment now about the muscle strength. All of you must be knowing about this MRC grading. I'll not go into the details. Grade 0 is the complete paralysis, and grade 5 is the normal power. I'm not going to repeat it. This is very well known, must be very well known to all of you. Only thing I want to point out the common mistakes with the examinees do in the exam. Once you ask him to test a muscle power, demonstrate a muscle power, many times the candidate simply puts supposing if he's asked to demonstrate a quadriceps power, he puts his hand on the patient's lower part of the shin and asks him to extend the limb. But please understand, first make sure that the patient has got at least power 3. Once you have demonstrated the patient has got power 3, only then you demonstrate the further grades. It may happen that you may be checking this way, going straight away, giving the resistance, which will not be the actual power. First, ensure that the patient has got a power 3 at least, this way, checking for the quadriceps. With the gravity eliminated, see whether the patient is able to extend the knee and then go for grade 4 and grade 5. This is the common mistakes which the candidates do in the exam. Now the next step is we have seen the bulk, we have seen the tone, we have talked about the power from 0 to 5. Then we come to the reflexes. Now reflexes of two types. One are the deep tendon reflexes and the superficial reflexes. Now deep tendon reflexes are the reflexes which are initiated by stimulating a stretched tendon. A tendon is first stretched, then stimulated, which produces a reflex action in that muscle. Now these are all the deep tendon reflexes which we are supposed to examine in the exam, and you have to memorize this particular table. These are the common deep tendon reflexes which we are able to see must examine in the exam. You must remember the muscle which is acting, the cord segment, and which is the peripheral nerve. Once you remember this table, you will be able to realize that if a biceps is absent, then most probably C5 is involved that way. Now let me show you example of in the further slides. You may not be knowing that the reflexes can also be graded. A grade 0 is the absent reflex. Grade 1 is present like a normal ankle jerk. Grade 2 is brisk like a normal knee jerk. Grade 3 is very brisk, and grade 4 is clonus. Now let me show you how to examine different reflexes. This is the reflex arc of a knee jerk. This is the position in which the knee jerk can be examined. This is the example of a normal knee jerk. The tendon is at a stretch, and then the tendon is scoped. This is the example of a knee jerk where there is hyperreflexia. You can see very obviously that the reflexes increase, and is most likely a case of upper motor neuron paralysis. The ankle jerk is examined in any of these three ways. Sometimes few examiners like to examine the prone position also. But these are the different ways in which a ankle jerk can be examined. This is the example of a normal ankle jerk. Please note everything the way the examiner is doing the. This is a normal ankle jerk. This is a increased ankle reflex. Again, upper motor neuron paralysis. Now, this is how you see a biceps reflex. The biceps tendon is not stretched, not stroked directly. The thumbnail is put over the tendon and then it is stroked. You can see the normal biceps and now see the increased bicep reflex. This is how the triceps reflex is examined. A normal triceps reflex, an increased triceps reflex. This is how a normal supinator reflex is checked. You see the contraction of the brachioradialis. This is how an increased supinator reflex would look like. Contraction of the brachioradialis. Now there is a small sign which is typical to cervical myelopathy patients. On flicking the distal phalanx, there is involuntary flexion of the rest of the fingers phalanges. This is Hoffman sign seen in cervical myelopathy. Now I was talking of grade 4. Sometimes the patellar conus is there. This is the way the patellar conus is checked. There is no patellar conus on this side. We see how patellar conus is checked. Ensure the patella is moving freely and then give a jerk. This is the example of a actual patellar conus present. Grade 4 of muscle reflex. Similarly, ankle conus can be checked in this way. Please see the position of the limb. Hip flexed, knee flexed, sudden jerk to the ankle and it causes, it is not so pronounced at this side, it was more pronounced on the right side. Now, this was about deep tendon reflexes. Now we are supposed to check about the superficial reflexes also. The superficial reflexes are so called because they are elicited by stroking a superficial structure like a skin or a cornea. Now these are the superficial reflexes which we are supposed to check in the exam, starting from plantar, anal, cremastic, bulbocavernous and abdominal. Again, the candidates are supposed to memorize this chart to know about which is the segment involved and which is the muscle which is involved. I'll show you examples. These are the abdominal reflexes. Now please see first. All the 4 quadrants of the abdomen are stimulated separately, and the abdominals are checked in that quadrant. Now there are 2 ways of doing it. This is the first way. This is the second way. In all the 4 different quadrants, the stroke is given from outside to inwards. Now please see this video once again. All 4 quadrants separately checked. Now we are talking of plantar reflexes. Plantar reflex. This is the way the plantar aspect of the foot is to be stroked in this manner. This is a normal response when the toes flex, and this is a normal response when there is a dorsiflexion and fanning of the toes. Now let us see. This is the normal response. This is a Babinski sign, which is a typical of upper motor neuron paralysis. Once it is present, there is no doubt about the presence of upper motor neuron paralysis. The next in the list is the cremastic reflex. Once you stroke the upper part of the thigh, the same side of the testicle moves up. This is again a superficial reflex. Now, please see this video carefully, how to check for an ankle wink. The perianal skin is stroked and it causes a involuntary contraction of the anal sphincter. There's one mistake in this video. The examiner is using a hypodermic needle, which should not be used. Use a awl pin to stroke the perianal sensation. Otherwise, the method is correct. Now, bulbocavernous reflex with the one finger inside the anus, the other hand stimulates the glans penis, and the finger inside the rectum feels for the contraction of the bulbocavernous. As far as the male is concerned, the other hand feels for the contraction of the bulbocavernous. In the females, it is done either by pulling on the catheter or by pressing on the mons pubis. While the one hand feels for pulling on the catheter and feeling for the contraction. Now the motor system is over. I'll come to the sensory system. You have to memorize the different tracts of the sensory system. I'll not go into details of these. Just for the sake of simplicity, these are the different modalities in the sensation to be checked: pain, temperature, touch, and joint sensation, proprioception, vibration. Pain and temperature are by the spinothalamic tracts. Half of the touch is also by spinothalamic tracts. The relative half is by the rest. All are from the dorsal tracts, which are dealing mostly with the vibration, position, sense, and stereognosis. Now I'll make it simpler for you to examine the sensory system. This is how you are supposed to examine all these modalities, which I'll show you by example. I'll not talk about this table. I already simplified it. You have to remember these dermatomes. You must, at the end of the examination, you must be able to find out that which dermatome is affected. Only then you will be able to decipher which is the level of the spinal cord injury or spinal cord insult. This is how you check the light touch. Either use the cotton in this manner, the manner shown, or even using a tip of the finger. Finger is also an internationally accepted method. Either of these two methods can be applied. Now, to check for the superficial pain, use a ordinary awl pin. Never use a hypodermic needle. Or there are special needle pins which are available, and you can use these pins to check for the superficial pain. Otherwise, a simple awl pin will suffice. Now, the previous which I have shown you is about the spinothalamic tract, about the dorsal tracts. These are the things which have to be checked. 2-point discrimination. If you remember your UG level neurology, different parts of the body can discriminate between the 2 points at a certain distance. A fingertip is able to discriminate at a very small distance, while the back of the hand, back skin can differentiate with a very large distance. This is what I mean. A fingertip will be able to distinguish a very small distance, while the back skin will be able to differentiate a very, very large gap. These are, criteria for the different areas of the body are given in the books. One has to know them, and then one can compare them in your patient if you know the normal. Position sense, you must. This is again a posterior column sensation. One wants to understand whether the patient is able to decipher the position of the joint or not. There are different steps. Shield the patient's eye. Explain the procedure to the patient first. What do you mean by up or down or neutral? The patient must know what you mean. Patient should be relaxed, and patient response is taken as either up, down, or neutral, or the neutral position. The examiner holds the proximal phalanx from the sides between the thumb and the index finger, and with the other hand, he gives 3 or 4 movements of the IPU joint or great toe, and then holds in a particular position. Now, and then ask the patient in which position the thumb is. Please see this. Asking the patient which position. Asking the patient. Asking the patient. Asking the patient. This is how it is checked. Now, this is just for the sake of completion, that the patient is able to recognize the size, shape, and weight and the form by holding different objects with his eyes closed. I think the last about, and this is the sensory system, is about the vibration. And for this, tuning fork is to be used mostly a 120 degree, 128 hertz or maximum 256 hertz tuning fork will be used. First, demonstrate to the patient what is meant by this test by stroking the tuning fork and keeping on a bony point, which is normal. Let the patient understand this is most likely to be normal in an orthopedic patient. Keep the stroked tuning fork on the lateral of the clavicle and let the patient know what is meant by vibration. And then you can check on the different bony points, whether the patient is able to appreciate the vibration of the tuning fork or not. And you must compare the two sides if there is asymmetrical paralysis. Now, this is the usual sequence which is seen in our patients. Once you are examining a patient of let us say as dorsal spine tuberculosis and examining the sensory loss from above downwards, patient will have a normal sensation till a particular level. Then from a small area, it may be a particular loss, maybe 50% loss. And after that beyond that area, there is a complete loss. This is a usual sequence which is found in the orthopedic patient. Normal above, then reduced sensations, and then absence of sensations. Now you must make a note of the bladder and bowel involvement. I can't discuss in details, but I'll give you a small idea about the things about the bladder. I'll not discuss the blood supply, but please remember these are the hallmarks of involving the bladder. Is there any perineal anesthesia? Whether the patient is able to have voluntary anal contraction, whether the great toe flexion is there or not. This is called sacral sparing. If these three are present, this is just in short about the different types of pneumogenic bladders which can be seen. If there is a lesion above T11, there is likely to be a spastic bladder. The bladder is not able to fill and it keeps on discharging quite often. While in a case of lesion which is beyond L2, it is a lower motor neuron bladder in which mixed picture from T12 to L1. I think I'll not go into details, but please remember that in case of spinal shock, initially when a spinal disease occurs, a spinal shock and all the reflexes are absent. As a spinal shock recovers, which is gauged by presence or return of bulbocavernous reflex. If the bulbocavernous reflex returns, look for whether the voluntary anal contraction is there or not, whether the flexion of the great toe is there or not, whether the sensation in the perineal are there or not. If these are there, the prognosis is good. Otherwise, prognosis is bad. This is just the same thing. Well, you must do a peer examination as the last part. Make a note of any bed sore. These are different grades of bed sore. I am not going to detail, starting from just peeling of the skin to the most deep level of the bed sore. Please make a note of the bed sore. Then what happened, sir?
I think your net has a problem.
Sir, again connect, share your PPT again, please.
Can you see my slides?
No,
yeah,
sir.
No, not yet, sir.
Can
Please
you see
again
my
share.
slides?
Share it again.
This was the first question, whether there is an upper motor neuron paralysis or a lower motor neuron paralysis. These are the differences. The basic difference remains that in upper motor neuron paralysis, there is increased
Sir, we can't see your PPT, sir.
tone, while in lower motor neuron paralysis, there is decreased tone.
So
The tendon reflexes are increased in upper motor neuron, while they are decreased in lower motor neuron. This is the basic difference.
Sudhir sir,
we can't see your PPT. Dr. Sudhir, please share it again.
Sir, please stop sharing and then share it again.
Then I told you, I mean, this is the first thing whether to decide about the upper motor neuron, lower motor neuron.
Dr. Sudhir.
Okay.
Dr. Sudhir, we can't see your PPT. So you stop share and again start
Can
share.
you hear me?
We can hear you, but we can't
I'm not
see
able to hear you.
Ravi, please call him.
Yeah, I'm just calling him.
I'm not able to hear you, sir.
Sir, I'm calling you. I'm calling you.
This is the formula we use to integrate the two things. What is the spinal level and what is the vertebral level?
सर वो यूज नहीं कर रहे हैं क्या हेडफोन्स?
नहीं डायरेक्ट कर रहे हैं. Okay, meanwhile, can we take one question for Dr. Sural?
Sir is also not picking my phone.
Dr. Sural, are you there?
Yes, I'm there.
Okay, there is a question. 1 minute.
मेरी आवाज आ रही बेटा?
Sir, आवाज आ रही है, but we can't see your slides.
Slides नहीं दिख रही हैं.
Okay, मैं मेरी 2 स्लाइड और कंटिन्यू कर दूं मैं इसको?
सर शेयर करके देखिए एक बार स्लाइड वो.
ओके, टॉक शेयर करके दोबारा शेयर करूं?
हाँ, शेयर माय स्क्रीन कर दीजिए.
Can you see it now?
ना नहीं आ रही सर अभी.
You are not able to see it. Let me give okay.
पहले से खोल लीजिए पीपीटी को.
Share screen.
उसके बाद स्क्रीन शेयर करिए. अभी नहीं आ रही सर. आई थिंक 1-2 स्लाइड आपको फिर से बतानी पड़ेंगी जैसे वो अपर मोटर न्यूरॉन लोअर मोटर न्यूरॉन.
Can you hear me?
We can hear you, but आपकी स्लाइड नहीं दिख रही सर अभी.
नहीं, can you hear me?
We can hear you.
Okay. Then let me complete. I mean,
so
I addressed
a
few questions initially, whether there is upper motor neuron paralysis or lower motor neuron paralysis, which can be gauged by these things. Once you have conducted the exam, you know whether the tone is increased or not. If the tone is increased, it is more likely to be a upper motor neuron. If the tone is decreased, it is going to be a flaccid paralysis. Similarly, if the reflexes are increased, the deep end reflexes are increased, it is upper motor neuron. If the deep end reflexes are decreased, it is lower motor neuron. The superficial reflexes will be absent in a case of upper motor neuron paralysis, while they may be present in a case of lower motor neuron paralysis. Now, you must understand, we have to integrate the spine, length of the spinal vertebral column is longer, length of the spinal cord is smaller. So the particular particular vertebra doesn't correspond to the same level in the spinal cord. I'll give you an example. If there is a thoracic, let's say if a
we can't see your PPT. We can't see your
vertebra is
PPT.
involved, the spinal cord segment which will involved will be dorsal spinal cord segment 8. If thoracic 9 vertebra is involved, then spinal cord thoracic 12 will be involved. This is what we mean by integrating the vertebra and the segmental level.
Manisha, Ravi, please call Sudhir sir.
Now we have to understand.
I have called him, but sir has put my phone on the side.
We have to comment upon whether the spinal cord compression, if it is present,
Ravi,
whether it is extra dural or intradural. If it is intradural, whether intramedullary, extramedullary. Now the basic difference between an extra dural and intradural compression would be that vertebral tenderness.
Sir, slide नहीं आ रही है.
Vertebral tenderness and deformity will be present in the extradural.
Dr. Kamran, he can't hear us. He is not listening to us.
This is the basic differences between the two types of compression. This is the last slide. Yes, Sumit. अरे यार ये क्या बकवास है.
अभिषेक सर को जरा फोन कर.
I'll share it once again. I'll share it once again.
Sir का phone ना busy आ जा रहा है. I think too many people are calling him.
Yeah. Actually, me was also calling. Sumit sir has called him.
Can you see my slide? Can you see my slides now?
Sir, आपको पहले एक बार बंद करके दोबारा on करना पड़ेगा.
Not yet.
No, sir.
Not yet.
Sir, please stop share first and then again share it.
मैं बंद करता हूँ यार. Okay, fine. I'll do that. अरे बकवास यार.
Not yet.
Slide share मैंने बंद कर दिया. मैं share screen करूँ.
When again?
Share screen. उसको बंद करूँ.
Okay, Dr. Sumit.
उसको start करूँ.
Oh, he's
अब दिख रहा है क्या? Can you see it now?
No,
Not
sir.
yet.
Dr.
अब
Sumit.
दिख रहा है कि नहीं?
नहीं दिख रहा सर.
हाँ नीचे दोबारा.
Dr. Sural, can you see me? Can you hear me?
Dr.
Dr.
Sural's
Sumit?
net connection is slow.
Okay, there is a, I think Dr. Kamran can take this question.
Yeah, go on.
Dr. Kamran, what is this Fajaksan sign? It is asked by Dr. Ayush RL from AIMS.
With regard to, I'm not actually, I cannot often remember the
दिख रहा है अभी slide मेरी?
thing. Fajaksan sign.
यार क्या बात है बॉस? मैं तो बिल्कुल सामने तो कब से आपको नहीं दिख रहा भैया?
Sorry, I cannot remember it offhand. कि Fajaksan sign
Okay,
क्या है.
actually he has put question for Dr. Sural and Dr. Sudhir Kapoor, but they were busy. So we take another question. Anyone can answer.
Bladder का दिख गया था bladder का?
They want an explanation of
Bladder वाला दिखा था bladder वाला कि नहीं?
sciatic list once again.
Yes.
Sciatic list का बता देते हैं.
Okay.
Dr. Sumit आपका आ गया वापस मैं बता देता हूँ.
Yeah. So sciatic list is basically because of the irritation. Yeah, can I continue?
Yes, sir. Yes, sir.
Yeah. So sciatic list is basically the nerve root compression is causing the irritation of the nerve root. So the patient will tilt on the side, which will relax the nerve root, right? So if it's an axillary nerve root, so like I'll just show you. If I stand here, and it's an axillary nerve root here, right? So, and one is the shoulder nerve root here, right? So to prevent this,
Shoulder disc, Sumit, disc prolapse.
Lateral disc, disc prolapse, disc prolapse. Yeah. So if the far lateral disc prolapse the shoulder, then he will tilt away. The axillary he will tilt on the same side so that the nerve root gets relaxed. So that's the list which occurs. It's not a shape, it's not a scoliosis, there's no rotation, it's just a postural tilt.
We will take Dr. Sudhir's presentation later on. I think I request Dr. Abhishek to be ready with his presentation. So,
Manish sir,
panelist,
by that time we can start the next presentation.
Yeah, we will start Dr. I think it has, yes, Dr. Abhishek.
Manish.
Yes, sir.
There was a question about Fezzer strength test.
Yes, sir.
You know what is that? Is that when you do a Lasix test and patient and you are able to elicit the same pain with which the patient has come, at that angle is the SLR test positive. And now you just bring the hip and knee flexion to few degree and that pain goes off. And then dorsiflex the foot at the ankle joint. The pain, the same pain with which the patient has come appears again. So that is what is that Fezzer strength test.
Okay. Thank you, sir.
Thank you, sir.
Dr. Abhishek, please.
Also called the Bagatt's test.
Yes, Dr. Shankar.
I mean, there is a confusion about the nomenclature. Some book says. Yeah.
The same as the Bagatt's test.
Can I begin?
Yes, sir. Dr. Abhishek, please.
Yeah, I'll try to do justification to how to read an X-ray and an MRI in 15 minutes. As people have said that you have to remember that case history, physical examination are important. And if we go in the sequence...
clear नहीं है. Abhishek, your voice is not very clear. थोड़ा increase कर दो और reverberate बात कर रही है. It's not very clear.
It is clear now?
Yeah, better.
Better now?
Yeah, it's better now.
So we have to go in an algorithm fashion, as Dr. Sudhir has mentioned. Case history is important. Physical examination is important. If we do not follow this and we directly jump to imaging, leaving X-rays or MRI and the candidate goes and answers an MRI. So you might have lead to a non-rational pathway, and which would lead to more mistakes for the postgraduate. For a standard question which is asked for a postgraduate, he should always know a standard AP and lateral view should always be ordered for any examination. It is faster. It gives you a basic outlook of vertebral shape, the disc shape. It might give you less information about the spine pathology in the early stages. I'll come to the specific X-rays. For the cervical spine, a standard AP and lateral X-ray is done, and which includes from C2 to almost to C6, C7. Sometimes we need an open mouth view, and sometimes we need a single view for a lower cervical or a cervical dorsal spine. The candidate should understand that we start any examination in the cervical spine from outside to inside. So he needs to remember the retropharyngeal space. In the upper cervical spine, it is around 4 mm. In the lower cervical spine, it is around 8 mm. So easier method is to remember is that you take the vertebral width, and more than half that vertebral width is significant at that space, would be a significant retropharyngeal space increase. The few lines which postgraduate needs to remember are almost these, but for us, if he remembers Chamberlain and McGregor line, which are almost the same of each other, he can make a diagnosis of basilar invagination. He should remember, know what is an Atlanto dense interval. It is around, in an X-ray, around 4 mm is usually standard. In children, it is around 5 mm in the X-ray. In CT, it is around 2 mm. This is sometimes you need to address to instability. So you need to get a flexion extension view. In a flexion view, in a normal view, it looks like that there is nothing abnormal. But once you do an extension view, you find that there is an instability at C1, C2, which is probably due to an os audentatum. Further, sometimes if you X-rays of the C1, C2 are kept, one is a Jefferson fracture, the fracture of the first vertebral arch. If you see the open mouth view, you'll find that there is increased distance between the odontoid and the lateral mass of the C1. So you know that there is a fracture and the widening of the arch has occurred, and probably a diagnosis cannot be reached on an X-ray, and you need to have a CT scan. This is X-ray showing a spondyloptosis of the C2 vertebra, which is also known as the hangman vertebra. I'm not going to go into the classification beyond. This is a fracture of the odontoid fracture because there is a flexion at the C2 vertebra, and plus you see there is an increase of the space, and there's a fracture. This is patient's same X-ray which shows a type 2 odontoid fracture. The Lanzo classification, everyone should know about it. Coming to cervical facet dislocation, as we told you that you need to have the anterior line, the posterior line, this line along the posterior spinous process, and the spinous line. So any break in this line would lead to show that there is a subluxation. If the subluxation is around 25%, it's a unifacetal dislocation. More than 25%, it's a bifacetal dislocation. Diagnosis is usually established by getting a CT scan. This clearly shows a locked facet at C6, C7. We can also see in the axial cut, this is also known as the reverse hamburger bun sign, where you find that the bun of the burger is there and the top is missing. So it's also known as a naked facet sign. The postgraduate should be able to differentiate between what is a flexion type and an extension type teardrop. A flexion type is more severe kind. It is associated with a severe kyphosis. It is usually found in the lower cervical spine, and it is usually associated with disruption of the PLC. The extension type are usually seen in older patients. They are usually avulsion injuries. They usually happen in the upper cervical spine, and they are less severe. One of the most other important fracture, which is the Clay-Shoulders fracture, it is an incidental fracture which might be seen in a cervical spine, which is imaged for other reasons. It occurs because the stickiness of the clay, and it's an avulsion fracture of the C2 fracture, which leads and a sudden flexion force, which leads to a fracture of the C2.
Dr. Abhishek, please increase your voice. Speak slightly loudly.
Okay.
You can come forward, yeah.
Sometimes we need to have oblique views. These oblique views are usually ordered when we have to see the neuroforamen. This is a patient of cervical radiculopathy, which shows that there is an obstruction of the neuroforamen and there is a posterior osteophyte which is causing that cervical radiculopathy. Am I audible now?
Yeah,
Yes.
okay.
You are audible now.
Yes, yes.
Better.
Coming to the lumbar spine, a standard AP and lateral view is usually ordered. It basically should be from T2 to the sacrum. It should show both the sacroiliac joints and the hip joints. So this basically, you again start from outside to inside. You can see the paravertebral shadows because of the psoas. You need to see the alignment of the spinous process. Do not comment upon the disc base on the AP view. You can have a look on the facets. You should have a look on the pedicles, the transverse process, and the interlaminar window, which might be decreased in the case of a spinal stenosis. Then you can have a look on the sacroiliac joints and both the hip joints. Similarly, for a lateral view, it basically gives you the vertebral height, the disc height, the neuroforamen, information about the neuroforamen, again the pars, and the spinous process. We need to order sometimes the oblique views. They are basically for spondylolisthesis or a pars interarticular fracture. You basically have to see the Scottish terrier. A Scottish terrier is a normal sign, which is basically compromised of the nose, which is formed by the transverse process, the eye by the pedicle, the ear by the superior articular process, the neck by the pars, and the front leg by the inferior articular process. So once you have a B-headed Scottish terrier sign, which is a pathognomic of a pars interarticular fracture or a spondylolisthesis. The other important sign which may be asked is an inverted Napoleon hat sign. This is the Napoleon hat sign. So if you have an inverted Napoleon hat sign, basically you are seeing the L5 vertebra end on, which usually signifies that you might be seeing a high-grade listhesis. We need to order sometimes flexion extension views. They basically give us information about the instability. So you get a flexion extension view. You have a vacuum disc, which again signifies there is some potential instability at that level. Standing X-rays, I will not go into the detail, but they give us basically the balance. They start from the C2 to both hips. They are the loading X-rays. They give us information about the lumbar balance, the SVA, PI, LL, the lumbar lordosis, and the pelvic tilt. I will not go into the details. They will be dealt in the scoliosis. The other thing, a candidate may be asked how to draw a Cobb's angle. It is basically drawn along the end vertebra. So you draw a line along the upper end plate of the upper vertebra, a lower on the lower end plate, the lower end plate of the lower vertebra. So basically you have, and which vertebra you need to see are the vertebra which have the least, which will have not the disc space parallel. A CT scan sometimes is asked when you would order a CT scan. So a CT scan is basically a multiple X-rays, and you basically see different shades of gray, the 0 being the normal and air being the most dark. So, and the bone being the most white. So it is the different shades of gray which you need to see. A 1 mm standard CT scan is usually done. The images can be re-engineered to give us a 2D image, then a 3D image, and then further it can be used for 3D printing. A contrast CT scan does not have so much limited, has no very limited role in spinal pathologies. A myelo CT may be ordered when there is MR incompatibility because of any prosthesis or because of any heart work, the pacemakers. It's an excellent choice for upper cervical injuries, and in emergency situation we will need to have a faster access. So because a CT can be done from top to bottom in a very fast situation, and it also gives us information about misplaced hardwares. Coming to the MRI, MRI basically is that the magnet leads to stimulation of the water molecule, and then it relaxes, and this relaxation is basically captured again by the camera, and this then is reformatted to give us the images.
So it gives a good contrast between different tissues of the body. It gives very poor detail of the bone. The candidate should know which image he's dealing with, and the key is the CSF. And the mnemonic is water, World War II. So you remember water is white on T2 weighted images. So we come to specific images. This is a T1 weighted images because the CSF is black. The normal would be is hyper intense on a T1 weighted image, and the mnemonic is my best friend is pretty cool. So these are the things which you can lead to. You should be worried about whenever you see a hypo intense shadow in a T1 weighted image. In a T1 weighted image, if you have a hypo intense shadow, which is basically a black shadow, this basically signifies that the bone marrow has lost and there is increased water content. So there is some process which is going wrong. So there might be an abnormal low signal on a T1 weighted image, which might give you some information that you might be dealing with a trauma, infection, or a cancer. Now, this is the same image of a same patient. Now a T2 weighted image because the CSF is now white. So this is a T2 weighted image. And these are the things which are usually seen black on a T2 weighted image: calcification, hemoglobin, fibrous, and tumors. And anything which is white on a T2 weighted image is basically considered that there is increased water content and it should be considered as pathological. And this might give you an indication that you might be dealing with trauma, infection, or cancer. So this is the same patient, and you have a complete high signal intensity, which is signifying that you are dealing with a multiple myeloma. There are certain special sequences sometimes which might be there available. The one which is most commonly is the stir images, which are usually available now with the MRI. They basically show the high water sensitivity, and water is basically bright. So it basically will give you information, and you see and compare the images to a T1 weighted image, and you compare it to the T1 weighted image, and you will find that water is white. So this is again a significant that there is increased inflammation, and there is a MRI of a spondylodiscitis. Few other images which are now commonly available are the diffusion weighted images. These images are basically dependent on the water mobility. The faster the water molecule basically diffuses, the weaker is the signal which is recorded. So a dark signal would signify blood and edema. This is basically used when we are having some confusion about benign osteoporotic fracture and a malignant osteoporotic fracture. A benign osteoporotic fracture would usually appear similarly as a dark appearance. Whereas if it is hyper intense, you basically consider that you might be dealing with a malignant osteoporotic fracture. Few cases why would you need a contrast enhanced MRI? Basically, it is done when you need to do evaluate a previous surgery, and you might be used when you want to show enhancement around inflammation neuroplasms. So this is an example. First is the spondylo case of a tubercular spine. You find that there is increased phlegm, so there is increased inflammation, and there is peripheral enhancement. Now you have a patient, I'm showing you the image where you can compare a recurrent disc to a scar tissue. In a recurrent disc, basically the disc material does not have any vascularity, has no vascularity. So there will be no contrast uptake when you have a recurrent disc. Now, if you have a scar tissue has some vascularity. So there will be peripheral enhancement of the scar tissue. So this is a case where you have might need a contrast enhanced MRI. Few examples I would like to give where a postgraduate is asked what are the differential diagnoses of vertebral plantar. So the mnemonic is I-built, and it is basically infection, metastasis, eosinophilic granuloma, the most common, the lymphomas, and T for trauma or tuberculosis. The tuberculosis can be an atypical tuberculosis. How do you differentiate between a tubercular and a pyogenic spondylodiscitis? The postgraduate should remember that a post-contrast image will show an ill-defined whenever you're dealing with a pyogenic, because the pathology is more aggressive as compared to a tubercular spondylitis. Therefore, the post-contrast images will be having a well-defined lesion. Plus, you will find ring abscesses, which are more commonly seen in a tubercular. These are the ring peripheral enhancement and the ring abscesses, which are more commonly seen in the tubercular spondylodiscitis. The other thing which is seen is the disc destruction. Since spondylodiscitis, pyogenic usually starts from the disc as compared to the vertebra, which the tubercular, which starts from the end plates. So the disc is usually preserved in the tubercular spondylitis as compared to a pyogenic spondylitis. The bony destructions is very common in pyogenic spondylitis as compared to tubercular spondylitis. The other important thing which a candidate is asked is how to differentiate between a benign osteoporotic fracture and a malignant osteoporotic fracture. You should remember that even in an MRI, that if you have normal posterior elements, that you might be dealing with the benign vertebral fracture as compared to a malignant vertebral fracture, where you might be dealing with an enhancement or a dark shadow in the posterior elements. The MR signal basically shows an irregular margin. These are smooth margins in a benign VCF. In a malignant, there is no smooth margin. In the diffusion weighted images, as I've clearly shown, there is no restriction or diffusion, so they will appear as bright. There is increased diffusion. So in the benign, there is no restricted diffusion, so they appear basically as dark. Whereas in malignant VCF, there is increased diffusion. So there is basically, they will appear hyper intense. Sometimes you might be asked, how will they appear in the PET? So you need to remember that the SUV is basically standard below the liver level. So you will be dealing with a low grade lesion as compared to a high grade lesion. In summary, I'm giving this chart. Every postgraduate should have this chart available. So you can, for a spinal TB is basically seen in more commonly in the thoracolumbar region. Pyogenic is more commonly seen in lumbar. So this chart is easily available. So every postgraduate can have a look at this chart and go about it. Thank you.
Thank you, Dr. Abhishek. Meanwhile, we can, ask a question to Dr. Abhishek. And Dr. Sudhir Kapoor, can you hear us?
Yes, dear, I can hear you.
You can show your last 5 slides starting from the upper motor and lower motor lesions. And meanwhile, when you are setting your screen, we will ask Dr. Abhishek questions. So I request the panelists to have questions for Dr. Abhishek.
Manish sir?
Yes, sir.
There are certain questions that I have messaged you. Just please see your
Yeah,
WhatsApp.
yeah, that I will see. I will see.
Dr. Abhishek?
Yes, sir.
Sir, please.
Dr. Abhishek, you explained very nicely. I just want to have one query. When should a doctor order for a contrast enhanced MRI in a spine? When should doctor should advise that?
Sir, I didn't get the question again. Can you please repeat?
Yeah. When should the clinician advise the patient to go for a contrast enhanced MRI?
See, I told you that a contrast enhanced MRI basically is when you're doing the first shot, you need to have, you are not clear about the pathology. You can have a contrast enhanced MRI. There are different which can be used. Once, if you want to have a look, it's basically ordered once you are dealing with a previous surgery, because you can differentiate between a scar tissue and scar tissue and the normal tissue.
Sometimes it happens that you go for a plain MRI and we clinically suspect some infective lesion in a primary lesion without there is no surgery previously, and the radiologist advises go for a contrast enhanced for further delineation of an infective lesion. Is that so?
I would not go about that because that a contrast will not give you a clear diagnosis still. A biopsy is the two-shot picture which it should be advised. Most of the images, stir images, can give you information about what you are dealing with, and which can be easily available when you are dealing with a. When you are dealing
Sir, your slide is okay now.
Okay, thank you.
Abhishek.
Abhishek, one question.
Abhishek, if you are suspecting infection and you are ordering a MRI, might as well get a contrast, because that will, the infection and the
adds to the cost. Okay, and now stir images are basically available, so contrast is more hype than other things.
Yeah, one question from Dr. Hitesh.
Abhishek, Yeah, it was a very nice presentation. Can you clarify on the canal dimensions in a case of spinal stenosis also?
Sir, that would be a degenerative. This is just how to read an X-ray and MRI. So if you can have in an MRI for a degenerative, you need to see the corner, sedimentation sign. So you can have the sedimentation sign. I might have a photograph available.
Yeah, Abhishek, I think Hitesh is asking about the cross-sectional diameter for a spinal stenosis on the transverse cuts. Is that right, Hitesh?
Yeah, yes.
Basically, he's asking about the diameter. You know, when would you say it's a critical stenosis on radiology?
These are arbitrary. Somebody can live with a 12 mm canal diameter. Somebody might not even be able to live with a 15 mm canal. So arbitrarily, it has been defined as anything less than 15 mm is considered, should be considered as spinal stenosis.
No, actually, Abhishek, now as a standard it is taken, especially in the lumbar canal, as a rule, if the cross-sectional diameter is less than 100, okay, 100 mm square, 10. As a cross section, 150 is okay, but if it falls to less than 100 mm square, then it is defined as critical stenosis. Even, I mean, in lumbar canal, at different levels they have different, but less than 100 is generally taken as critical stenosis.
Yeah, I agree with that because most of the literature does say 10 millimeter diameter and 100 square millimeter as a cross section is taken as a lumbar canal stenosis. For postgraduates, this should be okay.
Yeah.
Okay,
Exactly.
now can I request Dr. Sudhir Kapoor, because he had 5 slides remaining. So we will finish it off.
Is my slide visible?
Yes, sir, slides are visible. You can continue.
I'll just very briefly, I'll just remind the listeners about the order of the neurological examination. Higher functions, cranial nerves, then motor system. Motor system was bulk, power, tone, and reflexes. Reflexes were deep reflexes and the superficial reflexes. Then sensory system. Sensory system, I had told how to examine the fine touch, the pain, and the temperature and the vibration and all those things. Then we come to the bladder. Bladder, I had told you that the most critical thing is to decide about sacral sparing. That is whether there is a voluntary control of greater toe flexion, whether the sensation around the anus is present or not. These things do decide about the sacral sparing. If sacral sparing is there, the bladder function will come back. If the sacral sparing is not there, then we have to follow this simple statement which I have shown on the slide, whether to decide about whether there is an upper motor neuron paralysis bladder or a lower motor neuron or a mixed bladder. A lesion which is above T11 vertebra would have a spastic bladder. Means the bladder, there will be a failure to fill. There is a repeated urine discharge. If the lesion is beyond L2, it is mostly quadratic minor, and mostly it is a lower motor neuron bladder in which the bladder distends, and only then there is overflowing confidence. If there is involvement of T12 to L1, then there is a mixed picture because conus as well as quad is involved. This is in short about bladder. I'll not go into details of this. Same thing. Now you must do a PR examination to rule out any abscess present in the rectal examination. Make a note of the different any bed sore present. There are 4 different grades, starting from just peeling of the superficial skin to the most deep grade 4 bed sore, in which the deeper structures up to bone are involved. Then, if you remember, I had told from the very beginning that at the end of the examination, we should be able to answer 3 or 4 questions, whether the deficit is upper motor neuron or lower motor neuron. Now, these are the differentiating features between upper motor neuron lesion and the lower motor neuron lesion. The major ones are that in upper motor neuron lesion, there is increase in the tone. I had shown you example of a clasp knife increased tone. While in the case of lower motor neuron lesion, there will be loss of tone. Deep tendon reflexes will be increased in upper motor neuron. They will be decreased in lower motor neuron. Superficial reflexes will be absent in a case of upper motor neuron. In a case of lower motor neuron, they will be present unless the very segments which are supplying that particular superficial reflex are also involved. So this is in short the differentiation between upper motor neuron and the lower motor neuron lesions. Then we are supposed to tell what is the integration between the spinal vertebral level and the spinal cord level. If the candidates remember, the length of the vertebral column is more than the spinal cord. Spinal cord is short, so the segments in the spinal cord and the segments of the vertebral column, they are not corresponding. I'll make it more clear with the next slide. Supposing if there is a involvement of T7 dorsal 6 vertebra, there is, let us say there is a fracture of dorsal 6 vertebra, the spinal cord segment which will be involved will be dorsal 8. This is the formula which is used. If there is a dorsal 9 vertebra which is involved, the spinal cord segment which is involved will be, let us say, dorsal 12. This formula is summarized by the candidates to integrate the two levels. Now then we have to decide, answer the question, what is the plane of the spinal cord, extradural or intradural? Extradural, there are two things which are very, very pertinent. If there is a deformity and the tenderness. If the deformity and the tenderness is present in the examination, it is most likely a extradural compression. If the deformity and the tenderness are absent, there is no deformity and the spine is not tender, is likely to be intradural. To differentiate between intramedullary and extramedullary is little difficult, but in general, intramedullary lesions which will have neurological deficit much earlier than the extramedullary. This is the basic difference between the plane of the cord compression. I'll show you an example. Like in this patient who has got an obvious deformity at around D4 level. There is he has got all these findings present. Basically, he has got an angular deformity and tenderness. The deficit in this patient is likely to be extradural. Now, the other question to be answered about what is the extent of the deficit? Can we tell the stage of the disease? Now, this is the staging of the disease which has been devised by Dr. Tully and Dr. Kumar for tuberculosis of the spine. Grade 1 stage, when the deficit is minimum, even the patient may not be aware. When the doctor examines, he finds that the patient has got very fine signs of upper motor neuron paralysis. Gradually, these stages goes on increasing, and in the stage 4, which is the most severe, there is a flexor spasm, paralysis inflection, and there is a sphincter involvement. So these are the stages which have been described for tuberculosis, but we can superimpose these stages on other diseases also to tell about the severity of the disease. So once, as for the final diagnosis for a spinal disease is concerned, the candidate at the end of the examination must be able to tell whether it is an extradural compressive myelopathy, what is the stage of the paraplegia, what is the vertebral level, what is the dermatomal level, and what is the likely etiology. This should be the final diagnosis as far as the candidate is concerned at the end of the spinal examination. I think I'll finish it here.
Okay, thank you, Dr. Sudhir. There are a couple of questions for you, so you remain there. Dr. Shankaracharya.
Yeah.
Dr. Shankar, so you be ready. I have few questions for Dr. Sudhir. I will finish that. Yeah.
Dr. Sudhir has to first unshare his slide, unshare his screen before I
can. Please stop sharing your slide.
I'll do, sir. I'll do, sir.
Okay, Dr. Sudhir, there is one question for you.
Yes.
How to quantify by asking patient in Kumar classification of tuberculosis stage 3 versus 4 that patient is having less than 50% sensation or greater than 50% sensation?
Well, this is going to be a. You are presuming that the patient is intelligent enough to answer these things. To quantify 50%, the patient has to cooperate. If the patient can tell you, then you can definitely say. Otherwise, sphincter involvement, very severe muscle spasm. These things indicate stage 4, last stage. Okay. Then you have to see the picture in totality. Instead of relying upon your one finding, one has to see the picture in totality. If the sphincter involvement is there, Whether deficit is 50% or more, it hardly matters. It goes into stage 4.
Okay, these are kind of rapid fire questions. Now the second question is that single test to check motor power for C5 in shoulder abduction. Is it shoulder abduction or elbow flexion? Single test to check motor power for C5. Is it shoulder abduction or elbow flexion?
Dear sir, let us understand, this is not you are seeing the patient as a whole. If a nerve is supplying both the joints, you are supposed to examine both the joints.
Okay. And sir, what is the inverted supinator reflex and its significance?
Yeah, this is basically brachioradialis reflex. I will not be able to tell more about this thing. If somebody else wants to say, may say.
If when the hammer is put onto the supinator reflex and instead of contraction of the supinator, one gets flexion of the finger. That is called inversion of the supinator reflex.
Okay,
it is not supinator, Dr. Jain. I think it is a brachioradialis.
No, that is called inversion. If there is the movement seen is a contraction, flexion of the fingers, then it becomes the inversion of supinator reflex.
Important for cervical myelopathy.
Okay, yeah. Dr. Sudhir, one question for you. How to find out the site of lesion from T2 to T12 level, since there is no motor examination to localize the level? For example, in tuberculosis of D7 and D8 level.
I've understood the question. This level is not supplying any of the upper extremity. It is basically will be dependent upon sensory loss. We have definite sensory dermatomes on the trunk.
Okay.
They will decide.
Okay. Dr.
And the level of tenderness.
Okay. Dr. Sudhir, do we need to perform trapezius anterior deltoid and tibial anterior reflex in the examination?
Not routinely for orthopedic patients.
Okay. Now, should we perform bulbocavernous reflex in every patient or just in acute trauma?
No, it has to be done in every patient. If the patient has got a deficit, a massive deficit, and you have to examine all the things, not only in trauma.
Okay. Dr. Sudhir, are we supposed to perform adductor reflex or hamstring reflex?
Not really. I don't think that will be required.
Okay, and now I have to mention one thing, that Dr. Sudhir Kapoor has two very, popular books. One is on the examination of hip joint and one is on the examination of spine. So I think these are very handy books, and I request all the postgraduates to go through it. Dr. Shankaracharya.
Yeah. So Dr. Manish, one question from.
Okay.
Yeah, Dr. Sudhir, thanks for a nice presentation, though there were some interruptions. Some of the students want to know what is the difference between the autonomous and automatic bladder.
Autonomous and automatic.
Automatic bladder. Yes.
I'll not be able to tell you offhand.
Upper motor neuron bladder is called automatic.
I think this
and below the lower lesions called autonomous. Flaccid bladder is autonomous, while spastic bladder is automatic.
I'm not sure.
Okay, thank you.
Dr. Shankaracharya.
And one last thing, Dr. Sudhir, some of the PG wants to know, you have been using the words rigidity and spasticity interchangeably. Are they same or there's a difference between them?
They are used as interchangeable, but mostly rigidity is used for pyramidal tracts.
Extrapyramidal.
But otherwise, they are interchangeable. The spasticity is used for the extrapyramidal tract, which we are concerned. By pyramidal tracts, mostly rigidity, but they are donating increased tone in any case.
Okay. Now due to constraint of time, we will go to Dr. Shankaracharya's presentation. Dr. Shankaracharya, please share your screen.
Okay, good evening, everyone. I'm amazed that orthopedic surgeons and postgraduates are able to sit so long and listen to what is being going on. And thanks to Manish for that. He's done a marvelous job. And thank you all the speakers. I think most of my job of evaluation has been done. Now let me go straight to some clinical pictures. Who gets a lumbar disc prolapse? Can you hear me?
Yes, sir, you are clearly audible.
Yes,
okay.
Yes, sir.
Who gets a lumbar disc prolapse? Everyone in his lifetime will suffer from low back pain at least once in his lifetime. And the prevalence is about 80 to 90%. And about 10 to 25 of these will become persistent and chronic. However, the good news is that most of these back pains that occur in 80 to 90% of the population resolve over a period of time with conservative management. Most of the lumbar disc herniations occur at L4-5 and L5-S1. Disc prolapse that occur above L3 is called high lumbar disc, and it is important to know that because they behave differently and the risk of cauda is higher in them, though the commonest site of cauda equina is L4-5. How do I go forward? Okay, it can happen without any physical exertion. How does a disc prolapse occur in common person? It can happen without any physical exertion also. Suddenly you wake up and you find your back stiff and then you start getting some buttock pain and leg pain. But usually happens after a physical exertion, jerk or heavy lifting. Pain typically occurs in the back and radiates to the buttock, as has already been said in the examination, and goes down to the thighs, legs and toes depending on the level disc affected and the nerve affected. This is called radicular pain and may have numbness, paresthesia, weakness associated with it. So normally a normal disc is confined to its normal anatomy. So it stays, it has an annulus fibrosus and a nucleus pulposus. So annulus fibrosus is like a tire with about 20 layers, each layer obliquing itself at about 110 degrees attached to the bone above and below, vertebral end plate. And the nucleus pulposus is jelly-like substance, as we know, rich in hyaluronic acid and chondroitin sulfate, and absorbs water during the night. And when you wake up in the morning, you're normally taller. At the end of the day, so that's why you get more back pain, leg pain and back pain when you wake up with a disc prolapse in the morning. And any bulge from that is called a diffuse disc bulge. Whether it could be symmetric and causing foraminal stenosis, or it could be asymmetric. When the annulus fibrosus ruptures or starts rupturing of its many layers by crevices, then it is called protrusion when the nucleus comes out. When the nucleus comes out more and the thin layer of annulus is surrounding, but it is attached to the parent nucleus, it is called an extrusion. And when it is separate, it is called a sequestration or a sequestrum. So it has no connection with the parent disc. So where does the disc prolapse? That also is very important. A central disc herniation can compress many roots, and so it can have a mixed picture. However, most of the disc prolapse occurs in the posterolateral region or in the foramen or extraforaminal region. So that also is very important to know where the disc prolapse. And clinical history and examination can tell you a lot of these things, which Sumit and Dr. Sudhir Kapoor have explained so well. So you can have a central disc prolapse, you can have a posterolateral disc prolapse, you can have a foramen disc prolapse or a subarticular disc prolapse, or you can have an extraforaminal, because this is a cylindrical disc is cylindrical, so disc can prolapse anywhere. It can also prolapse anteriorly, but normally is asymptomatic there. So this is also very important for postgraduates to know that in addition to the place where disc prolapses, it can go up or down. So if it goes down to the pedicle, it can be along the pedicle and in the subarticular region. It can go up into the vertebral body. So it can migrate. If it is sequestrated or protruded with a bulge, it can migrate up and down. And this is a picture, very good picture from McNabb, who's written long ago a book on low back pain. And I find this very useful. And he's divided the lumbar vertebra and the disc as an American into first floor, second floor, and third floor. So you must know which floor is the disc in and which part of the vertebral body the disc is, whether it is central, subarticular, or foraminal, or extraforaminal. And that is important to understand from clinical history, examination, and MRI. So you should be able to read the MRI. As soon as you become orthopedic surgeons, you will start seeing spine patients, and more spine patients are seen by orthopedic surgeons than spine surgeons. Things also you must know is small to moderate central disc prolapse or annular bulge may present only with back pain. So they may not have leg pain or buttock pain, and so you may be taken off guard. So it is important that bulges or small central disc prolapse may have back pain. Lateral and extraforaminal disc prolapse will mainly have leg pain and no back pain because it is on the foramen. So they usually press on the exiting nerve root and the traversing nerve root escapes. So they have only leg pain, and that is important to know, which is the exiting nerve root and which is the traversing nerve root. Usually posterolateral disc touch the traversing nerve root. So the exiting nerve root escapes in that. High lumbar disc, as I said earlier, may have mixed symptoms because they affect multiple roots, and you must be aware of that. So a very good history taking and clinical examination, you will be able to differentiate mentally as to where is the disc prolapse. And then you correlate your findings by examination and then by your MRI findings. So this has all been told by 3 speakers earlier, that in the front, in the groin area, you have the L1, in the front of the thigh is L3, knee and medial aspect of the leg is L4, outer aspect of the leg is L5, and the back and the heel and the back of the calf is S1. You stand on S1 and you sit on S2 and 3. And a quick clinical examination is in the clinic. I can just tell you that you can, if you stand on your tiptoes, you are standing on your S1. If you're standing on your heel, you are standing on your L5. If you can sit down and get up, your L4 is all right. And once you can sit down and sit crossed legs, your hip and knee mostly are all right. So this is a quick cursory clinical examination in a clinic or in an examination hall. L4 typically is tibialis anterior, so you can ask them to do dorsiflexion and inversion. So these are tricks you must know, and you must also know special dermatodermal areas where it is specific for L5. For example, the web between the first and the second toe. I think Sumit has already shown you what he meant by a shoulder presentation and an axillary presentation, and it is important that you should, from the list and the side where the leg buttock paining, you will be able to mentally perceive which side, whether it's an axillary or a shoulder presentation. But sometimes this may not be accurate. Examination of hip and knee is very, very important. A detailed neurological examination is essential. We have gone great lengths that also peripheral pulses should not be ruled, should always be checked. So just don't jump to see an MRI and then make a diagnosis without checking the peripheral pulses. I have seen so many mistakes and surgery done without doing peripheral pulses and patient being in trouble. So that is also important. We have already spoken about the femoral straight leg raise test and the femoral stretch test. So I will not spend much time on it. You already know what this test is. What is important is, why is the Begard sign described, is that when you stretch it when at over 75, you can get pain from the sacroiliac joint or from a hamstring stretch. That can also give you pain. So that may confuse you. So you lower the leg down a little bit when there is no more pain, and then you dorsiflex the foot, and that will tell you a sciatic stretch, which is stretching over the disc which is inflamed. And to confirm it, you do the bowstring test, which I think Sumit explained to you very well. Then you press on the nerve, and that also gives you pain. So you're confirmed of it. And that's why the importance of this test. The femoral stretch test has also been described. And so this is important mentally to memorize, as Professor Sudhir Kapoor said, what is what, sir. And that I explained to you how to quickly examine this. I will spend a couple of minutes on cauda equina. This is our only medical surgical emergency, and it is important to know what is cauda equina. L1, at L1, you have the conus, and below that you have the cauda, which means cauda means a horse's tail. So it means all the nerve roots are coming out there, and a large disc prolapse centrally can cause compression of all the nerves. And the biggest problem is it can involve bowel and bladder dysfunction. So to say that the person has cauda equina, he must usually have a saddle anesthesia, bowel bladder dysfunction, and variable sensory and motor function. And they don't follow a fixed pattern. So that is important to know. So they basically have bilateral saddle anesthesia, bilateral posterior buttock and thigh and leg numbness, and weakness with differential weakness of the legs, atrophy of the calves if it is long standing. So this is a only surgical emergency. So as soon as possible, you should operate. And that is important. And because this may present anywhere in the country and you may not get, as orthopedic surgeons, once you pass, you may have to know how to handle a cauda equina and operate on that. What are the investigations have already been said, but for diagnosing a lumbar disc prolapse, MRI is probably the investigation of choice. However, X-ray is very important, especially when you decide to do an operation, because level sacralization, lumbarization, 4 lumbar vertebra, 5 lumbar vertebra, and all that can be confusing. And so the commonest mistake if people do while doing surgeries, if they have not checked with an X-ray and the MRI, the level is the wrong level surgery. So the commonest mistake in lumbar spine surgery is wrong level surgery. So we always check the levels, not once, but twice or thrice. Sometimes subtle lysis, spondylolysis may be missed. And so CT scan is very important. Facet cyst, facet arthropathies may also coexist with a disc prolapse in slightly middle age. So that is also important, but not always. So essentially are your blood test, your MRI, and an X-ray. For patients with multiple comorbid situations like diabetes, neuropathy, EMG and nerve conduction studies are required, because suddenly you find a patient with a complete foot drop but with not some major compression, and you get worried. So sometimes you have a moderate compression and you may want to do a surgery, but basically the patient is suffering from a diabetic neuropathy. So essentially, when you have coexisting diseases, it's very important to get EMG and nerve conduction test, and that is to be kept in mind. So once you have made your diagnosis, at this point, I must say that when you are diagnosing disc prolapse, I have not put that slide, but it's very important that you must eliminate other diagnoses which can mimic disc prolapse. A pelvic inflammatory disease can mimic disc prolapse. Sacroiliitis or inflammatory arthropathy can mimic disc prolapse. Even prostatitis or prostate problems can mimic disc prolapse. Abdominal aneurysm can do that. Abdominal problems can do that. So many conditions can mimic. So you must do a thorough examination. It is very, very important, and take a proper history. Once you have made up your mind that this patient has got disc prolapse and no other problems, what is the treatment plan? Most 90% of the disc prolapse, he resolved with conservative treatment, mainly with analgesic, some anti-inflammatory, and at best, very rare cases, you may give them a short course of steroid for 2 to 3 days. Bed rest is only for pain relief, so there is no role of major bed rest. As soon as he can get up and walking, I allow my patients to walk. Once the pain is resolved, then you start focusing on a long-term rehabilitation. So physical therapy is very important. So let us look at this disc prolapse, because when you graduate and become consultants at different places in the country, suddenly you get an MRI with a large disc prolapse like this. And I have seen a lot of times patients getting operated for large disc prolapse because it occupies almost 80% of the canal. So it is very important to know that sequestrated disc normally resorb because of macrophages, phagocytes, and things like that. So they resorb over a period of time. And you can see these two MRIs on presentation, and 10 months later, the disc has completely resolved. So most of the disc prolapse resolve, and size does not matter. It is one thing here. And this very good paper, which has been published recently, it says the percentage of spinal canal occupied by herniated disc does not predict which patients will fail non-operative treatment and require surgery. In this, the exclusion criteria, they've excluded cauda equina and hard disc and other things. But basically, if you have a large soft disc at L4, 5, L5, S1, and he has no more motor deficit or neurological deficit, no bowel bladder symptoms, you can treat him conservatively. And most of them will resolve about 6 to 8 weeks time. Any other role of conservative treatment? Traction has no proven benefit. There is no class evidence, and bracing is also not beneficial, but helpful in patients because it gives them some comfort of support. Now, epidural steroids are very commonly used since my early post-graduation days in Safdarjung. I've seen caudal epidural being given in bulk. However, caudal epidural as a route for giving steroids has gradually gone off, and nowadays we either give an interlaminar approach or a transforaminal approach, which is more specific and better and has got better outcome and more predictable. you can exactly see, localize where your needle is, and you can check with the dye, and then you give the injection, and they gave a very good result. In my unit, we do a lot of these blocks ourselves, and they give good results. So if a patient is being treated by you for conservative disc prolapse, how long do you wait? Essentially, if you wait too long, the nerve gets memory, gets scarred, and the patient is symptomatic, especially if a foraminal or extraforaminal disc, and so you don't get a very good outcome. So essentially, waiting for beyond 8 to 12 weeks is not beneficial. So if your patient is not getting better by about 12 weeks, that is 3 months, then it is advisable to go for surgery. Normally, patients don't wait that long, but you can wait as long as the patient has no deficit or problem. So what are the indications for surgery? I just told you 90-95% of disc prolapse resolved with conservative treatment. So what are the indications for surgery? So there are only 3 indications for surgery: cauda equina, progressive motor loss, and intractable pain where the patient wants that he can't live like this anymore and he wants surgery for better quality of life. Microdiscectomy still remains the gold standard, and all the other newer methods of discectomy are comparable to microdiscectomy. So still this is a gold standard. And if you can do a good microdiscectomy well, I think you are fine in treating the patients effectively, because you should not do any harm. And the complication rate of dural tears, discitis, or root injuries with a microdiscectomy is less than 2%. So let me take you with some schematic diagrams, because I thought time doesn't allow us. So you give an incision between the 2 spinous processes. You give a midline incision. Lumbar fascia, you can go slightly off midline, and you can see then you have the multifidus muscle. And the multifidus muscle attachment, as I have shown, is there. So you erase the multifidus muscle with your cautery, and then you will have to nibble it with your kerrison ronger or a bird. So once you nibble it, you have this much area exposed. The ligamentum flavum is attached slightly higher up on the undersurface of the lamina at the higher vertebral lamina, while in the lower laminar, superior margin of the lower lamina, it is attached. So if you put your kerrison ronger inadvertently lower, you may damage the dura and cause a dural leak, while you are much safer by putting the kerrison ronger superiorly, as you can see in the diagram. So once you have removed with the kerrison, you will have the ligamentum flavum. So the ligamentum flavum is attached higher up in the bone in the lamina above and on the margin in the lamina. So this is one safe area where you can start removing the lamina, or you can incise the lamina. There are many ways. You can keep the lamina, take a fold up, whatever you want to do, but you have to remove, raise the lamina. And once you raise the lamina, you will see where the disc prolapse is at the level of L5S1. The disc prolapse is at the level of the in the window, the foraminal window. As you grow higher up, excuse me, higher up, you have to cut more and more lamina. At L2-3, you may have to do a hemilaminectomy as well. So this is a prolapsed disc. If it is on the shoulder, you can easily take it out. If it is in the axilla and it is very tight, then you may have to tease it out of the axilla. So this is how a disc prolapse is done. And then usually it's about 1.5 centimeters incision. So there are, as I said, there are various types of disc prolapses, and I can't go into details because Manish wants to teach the whole of spine surgery in 2 hours, which is impossible. So essentially in a sequestrectomy, we do what which is called removal of the sequestrum, which essentially means we remove the free fragment and we go through the tiny hole or the tear that is there in the annulus, and with a 2 millimeter kerrison pituitary, we take out whatever free fragment is there. So that is called a minimal sequestrectomy with removal of free fragments. However, when you have a cauda equina which is occupying the whole of the canal, you will have to do an aggressive discectomy. So if you do an aggressive discectomy, then you will end up with more back pain. But sometimes you have to do that, and it is important to counsel this patient. For example, this patient, you find that patient has 3 disc prolapse with a large disc prolapse leading to cauda equina, and this patient may have higher incidence of back pain. And if I do a sequestrectomy with just removal of the free fragment, I may have a higher incidence of recurrent disc. So this is a trade-off. And once with experience, you know how much to do and how much is enough. And that comes with only experience. There are lots of complications. So with discectomy, this is the simplest operation and yet the most complicated. And it can take 20 minutes to multiple hours. And sometimes you may come off after a surgery, which has happened with me so many times, where I'm not happy with what I have done. So it is very important to plan your case very well and know what you're doing. So don't take these cases lightly. You can have vascular injury, and there are reports that the patient, where surgeon has gone far anterior and nibbled onto the abdominal aorta and caused vascular injury. Nerve root injury is fairly common. Dural tear is also common. Infection, obviously you can have infective discitis, post-op discitis, and that's a nightmare. If you get infection in spine, it is a big nightmare. Or in other matter, if you get infection in spine or joints, it's a big problem. So we are very, very careful. Back pain increases if you do in aggressive discectomy. Recurrent disc herniation occurs about 6%, 4 to 6% in normal population. In diabetics, it is more. In smokers, it is more. And obviously, the amount of discectomy you do, it depends. And the amount of annular tears. I'll tell you a bit about annular tear, but there's not much time. So if you have a large annular tear or a defect, then the recurrent disc herniation chance is more. If you have a very small annular tear, the chance is less. Cauda equina is a big problem, and then there are medical complications. Two slides on what are the types of disc. Mentally, everybody would think that the disc prolapses when the annulus gives way. Yes, about 50% of disc prolapses when the annulus gives way. And the annulus can have a small hole, may have no hole, or may have a large hole, or may have a large tear. So depending on that, the outcome has also been described by this very good study, which is quoted most of the time, Eugene Carigi et al. And it tells us that which disc prolapse in which type will do well. Also, I would suggest all postgraduates to read this landmark paper from Dr. Rajshekharan, Ajay Shetty, and Rishi, which did a very good study, because MRI does not show the bone end plate well. And X-ray also does not show the bone end plate very well. And they found out that about 50 to 60% of disc prolapse occurs because of end plate fracture or rim failure. And 50% occurs because of annular failure. Until date, we always knew that disc prolapse occurs because of annular failure. And this is an important thing to keep in mind, because you must know all the things that are happening with this study. So the take-home message is history and clinical examination is very, very important in making a diagnosis. And I think must thank Manish for giving 3 lectures for only history taking and clinical examination. We have had a special class on MRI and how to read an MRI and X-rays. Most of the disc prolapse are treated conservatively. Only absolute indication is cauda equina or increasing neurological deficit or intractable pain. Microscopic discectomy remains the gold standard procedure. There are many more methods of taking the disc out, as endoscopic, interlaminar, transforaminal, and more minimally invasive procedures. But these 3 are more popular. And if you can learn these, well, you can give a better outcome with lesser complications, but it has a longer learning curve. And you must be aware of the complications and recognize them. And I thank everyone for giving me this time. I got this slide from Dr. Rajshekharan. He says, stay positive and test negative in this time of Corona crisis, where there's so much of academics and no clinical work. Thank you, Manish.
Thank you, sir, for such an informative and good lecture. And I have received so many calls because there was some interruption in the YouTube. We have restored it. I request Dr. Anil Jain to be ready with his presentation. Dr. Shankar, you can stop the share screen and we can have few questions for Dr. Shankar. 1 or 2 questions. Dr. Anil Jain, can you hear me? Dr. Anil Jain?
Yes, I'm able to hear you.
Sir, you share your screen and we can have few questions for Dr. Shankaracharya.
I have a question to Dr. Shankar. Dr. Shankar, Dr. Kamran. Sir, one is that how much of disc would you remove when you are doing a routine discectomy, and when would you consider a fusion?
Shankar, please unshare your screen.
Yeah, I'm just doing that, sir. 1 second. Okay, I have answered. You are all right?
Yeah.
Okay.
There is a
Yes,
question from Dr.
Kamran had a question, says how much discectomy is enough and when do you do a full fusion? So basically the answer is that it is a spectrum from 0 to 10. And as I said, you can go from just removing the free fragment to going to a full aggressive discectomy. And that it depends on case to case. So there is no fixed answer to that. But usually in present day, we do sequestrectomy, removal of the fragment. You should not cut the annulus more than 6 millimeters so that you it's a small incision. The incision should always be linear and not cruciate, as we used to study in our postgraduates. In linear incision should not be more than 6 to 7 millimeters. And then you use your 2 and maximum 2.5 millimeter pituitary to take out the free fragments. Don't use a curate or scrape it too aggressively. Don't take out the annulus, and that should be enough. However, if you have a large disc prolapse and a large annular tear, you may have to do it a little more. It is very rare in my practice that I do a primary fusion, but there is an indication of primary fusion in large disc prolapses, heavy patient, high BMI, and poor sagittal profile. And then Abhay says wine, dine, and spine to everyone. Well, there's nothing apart from water here. And so there is some small indications for fusion.
Okay, 1 minute. Because of constraint of time, can we go to Dr. Anil Jain's lecture?
Okay.
And we'll take questions and later on. Vineet will take questions later because we have very less time. So at the end, because we have 3 lectures remaining. Dr. Anil Jain, please.
Yeah, thanks Manish for giving me this opportunity. Well, I know that 15 minutes too big a time, too small a time to talk everything about TV spine evaluation and management. But what I will do, I'll just spend few minutes in the diagnosis and some of the tips which the postgraduate student must express in the examination. Well, we all know that it is an extrapulmonary tuberculosis, and as extrapulmonary, it is paucibacillary. So paucibacillary causes, has its problem of lower bacteriologic diagnosis and source detection rate. And that's the reason why we have a little difficulty ascertaining the diagnosis in a spinal or extrapulmonary tuberculosis. And out of all, 50% is spinal tuberculosis. Now, if you look at the pathogenesis of disease, the disease starts as inflammation to the vertebral body, and that goes on to produce bone loss, bone destruction, to spinal deformity and neural complication. So this is the sequence of pathology, pathogenesis of the disease. Now, whenever you want to diagnose on clinical and on X-ray ground, where the classical clinical finding of a paraspinal tenderness, kyphotic deformity, some cold abscesses with or without neural deficit, and a classical X-ray finding which has been described as osteopenia, obliteration, reduction and destruction of the disc spaces, and a kyphotic deformity, prevertebral shadows, increase in the prevertebral space and the paravertebral shadows. So when you diagnose clinically in a with a deformity, probably we are already very late, and patient must be symptomatic for at least 3 to 6 to 9 months. That is why probably now we have to understand the pathogenesis of disease and move on making an early diagnosis where this classical radiological picture is not there. We have to diagnose it before an obvious deformity and a neural deficit. So for that, suspicion has to be clinical and clinico-radiological. Any patient with persistent back pain, localized back pain for 3 months or more, with or without tenderness or spasm, with or without constitutional symptom, and with maybe subtle radiological sign or without subtle radiological sign, is something which we need to evaluate by for sure by imaging. And well, in olden time it used to be multiple imaging, but now MRI is the gold standard. So these patients must be subjected for must be put for an MRI evaluation. Now this is what I was talking, that it starts as inflammation, and gradually the disc starts herniating into the inflamed vertebral body with the damage to subchondral bone. And as the disease continues, this destruction and inflammation continues, the whole disc herniates into the disease inflamed bone, and later on the anterior bone loss takes place, and that is how the kyphosis starts appearing, and the diseased tissue enters into the spinal canal to produce a neural deficit. Now this keep this pathogenesis in mind. Patient starts presenting with some pain at this point of time when the inflammation has started, with or without constitutional symptom. Further pain increases, local signs starts appearing, and if further ignored, then kyphos appeared or neural deficit appear, and it takes time. So now, if at this point of time you are able to get some X-ray finding like that, reduction in disc spaces, then we are more or less far sure that probably there is a definitely some underlying destructive disease or inflammatory or infective disease underlying. However, and that is why on this clinical imaging predictor, if you get all imaging, then we should be able to localize the lesion. We should be able to identify and diagnose the condition. Now, in the present time, all imaging are generally not used. So MRI remains the gold standard. So a presumptive case with a persistent finding of localized pain, and if these are subtle X-ray finding of increased localized prevertebral shadow and some straightening of spine or reduction of disc spaces, we should be able to diagnose with the MRI before a kyphotic deformity appears. And if you fail to subject and diagnose at this point of time, then I'm sure in some more weeks or in some more months, this kind of a classical radiological picture is going to come up. And that is what I was trying to, that if we understand the pathogenesis of disease, then we are able to diagnose before a classical deformity or neural deficit appears. Now, when an MRI has been done, then these are the findings which are very important. These patients, they have a contiguous vertebral body involvement. You could see these 5-6 vertebral body. Well, on X-ray, you may see 2 or 3 vertebral body, but 3 or more vertebral body may be inflamed. So contiguous vertebral body involvement, relative preservation of disc spaces, subligamentous extension, which is low signal in T1 and a bright in T2 weighted images, with large pre and paravertebral abscesses, which are septated. You could see this septated paravertebral abscesses, intraosseous abscesses, and epidural involvement. Now, with the constellation of these findings, we are now more or less 90% sure that we are dealing with a case of tuberculosis of spine. However, this is what is a clinical imaging diagnosis. Now, this is another example I'm putting here. Patient is symptomatic, and if you could see, there is a reduction in the disc spaces, and this vertebral body has anterior vertebral body erosion. This is another body which has erosion, and the MRI finding. You could see these are the contiguous vertebral body involvement, and this is the subligamentous collection, which is septated here. You could see bright in T2, low signal in T1, and intraosseous lesion. So now we are more or less sure, and this patient, we ascertained the diagnosis bacteriologically as well. So with these findings, in almost 90% instances, we are able to make a confident diagnosis. Now, on the contrary, if you have a heterogeneous signal with some normal intervening vertebral body, now these are not the patient or MRI picture to be taken as tuberculosis by all means. The differential diagnosis here, it's going to be sinister conditions like myeloma, multiple myeloma, lymphoma. So hence, we must take biopsy in all such cases. There is no place for empiric treatment as starting empiric ATT. Now, we have made a clinical suspicions, or we have done an imaging. So we have to ascertain the diagnosis either by some way, whether by MRI where you have a classical finding. If not, then tissue, open or percutaneous biopsy. And once you have taken a tissue, then microbiological, molecular or histological diagnosis must be done. I think this is a very important slide which I'm just going to show, and this slide is there in one of the recent clinical current concept review, which has been published in Journal Bone Joint Surgery American April issue. If you look at this triangle, then culture is the gold standard, which to ascertain the diagnosis in tuberculosis. And as I said, we are dealing with a paucibacillary. So in best of the lab, chances of getting a bacterial growth is somewhere between 30 to 50% in a virgin case. And that all depends on the quality of lab. Now, the next in hierarchy comes molecular method, which may be gene experts, line probe assay. Well, I've written data is not known, but now this data, some data has emerged in some of the series, and even we are likely to submit for publication one of the consecutive series of cases where molecular methods, gene experts and line probe has not only improved our diagnostic accuracy, but is also able to suggest or indicate if there is any drug resistance to rifampicin or rifampicin and INH in line probe is there. Now coming to FB smear, which is a little lower than these two, and here again 10 to 30% instances we are able to demonstrate organism. Then the next is histological diagnosis. Now there are two kind of reports we get, as consistent and suggestive. Now if you get an granuloma proper and all other findings, then it is a consistent with tuberculosis. However, if the granuloma is not there, caseating granuloma is not there, then in that case it is always a suggestive. So 60% is, if you take 100 histology, then 60% are consistent while 35% are suggestive. So these four methods are able to, if done all simultaneously, then we are able to ascertain the diagnosis in a paucibacillary spinal lesion in almost 100% instances, because each of the method is having some percentage of positivity. Now here, if you could see that radiological and imaging studies, clinical suspicion and therapeutic response to ATT, they are very low. And that is why confirmation, ascertaining a diagnosis in osteoarticular or spinal tuberculosis is a hierarchical diagnosis where you have to put everything together. Never rely on treating them on a clinical suspicion alone, or a only therapeutic response alone, or only imaging or and radiologically, unless your MRI finding are characteristic. Now, coming to the treatment, I think one thing is sure, that mainstay of treatment is a prolonged, continuous multi-drug therapy, and surgery is indicated in certain individual cases. Type of surgery, whether the patient has paraplegia or not a paraplegia, TB spine in children, granulomas or late onset paraplegia, these are the conditions which require individualized approach. Now, this treatment of tuberculosis has evolved after a BMRC study on 750 patients by British Medical Research Council between 1950 to 75, where 2 to 3 drugs, bed rest or ambulant, radical clearance or conservative, radical clearance or debridement were compared in different parts of the world. And it was reported that there is no difference on healing. There were many lacunae, but at least this study has conclusively proved that it is a medical disease to be treated medically. Now, evolution of drug therapy, there are many issues. What are the drugs? What are the volumes? What are the regimen, whether intermittent or daily dose? How long it should be treated? Is there any regimen difference in children? And failure to drug therapy. So these are the 5 questions which are put to students and put to our clinical practice every day in a different clinical situation. Now, rationality of this is ATT is a multi-drug, because in a lesion there are various kind of organism. Some are extracellular, rapidly dividing, acted upon by INH, streptomycin, ethambutol. Some of them are extracellular, slowly or intermittently dividing. They were acted upon by rifampicin. Some are intracellular, intermittently dividing. They are pyrazinamide. And some of them are the dormant bacilli where no drugs act. And since there are the cluster or collection of organisms have a different division and hence acted by different drugs, and that is why it is a multi-drug combination to be given as ATT. Now next is intermittent or daily doses, and the doses, the current drug combination is rifampicin, INH, ethambutol, pyrazinamide for 2 months. After that, pyrazinamide can be withdrawn, streptomycin, rifampicin, INH and ethambutol to be continued in the maintenance phase for whole duration. Well, it used to be 2 drugs 3-4 years ago, but INH resistance has been demonstrated in some part of India, particularly in Gujarat, and that is why all treatment protocols now include rifampicin, INH and ethambutol as a maintenance. Now, the next was, should we give an intermittent or daily doses? Well, this intermittent or daily doses, both are scientific. Intermittent acts on lag effect, where if the bacteria is put to some drug concentration in the blood, then bacteria undergoes suppression. And even if the drug is withdrawn, bacteria takes 24 hours to reactivate, 24 to 48 hours. And that was the rationale of lag effect. However, and that is why 3 times per week were advocated to improve the compliance, and so as to make it possible that this could be an supervised chemotherapy. However, the problem with intermittent doses was that if some dose is missed, then it becomes inadequate treatment, and that was the risk of emergence of drug resistance. So now all guidelines have says that it has to be daily doses regimen. So there is no confusion, no controversy. It is daily doses regimen. Short course or long course? Yes, this is still an unresolved issue. There are various groups to talks about 6 months, 9 months, 12 months, and this all is because of pulmonary has recommends short course regimen, because there you are able to demonstrate bacterial sterility of pulmonary lesion by sputum, repeated sputum examination, and then you give 4 months ATT, and that's good enough. However, in a bone and joint tuberculosis, it is difficult to demonstrate when the lesion becomes bacteriologically sterile. And that is why the opinion is divided between 6, 9, and 12 months, because our healed status used to be completion of regimen, whatever pulmonary group gave, and no recurrence for 2 years. And this duration of treatment, in a review of literature, we find that there is a lack of consensus what constitute healed status in the literature. So we, the work is going on to define what is the end point of treatment. And when the contrast MRI was taken to decide the end point of treatment, what we found is that not all lesions, we could demonstrate 35% lesion patients achieving healed status at 8 months, 60% at 12 months, 90% at 18 months. And that is why we recommended that it is unscientific to stop ATT by fixed time schedule. Lesion must heal. So then, and this is the example you could see here. This is the lesion which is completely resolved on MRI. And this is the lesion and which is completely resolved on MRI. But then the persistent bone edema on a contrast MRI was an issue, because this edema could be an inflammation of bone or it could be a disease per se. And this inflammation, this persistent bone edema was to be resolved. So that is why MRI evaluated lesions were overtreated. So then we again monitored with PET scan, and we concluded, and these were all histologically and bacteriologically proven cases. And what we could see that again, all those same findings were, we were able to ascertain that there were some patients showing healing at a shorter time, while others showing healing at a longer time. But PET scan was able to cut short and demonstrate healed lesion earlier than the MRI scan. But one thing what we concluded, if there is any chance stainless steel implant, then PET remains the only method to demonstrate healed status. So again, we concluded that you have to treat any spinal TB lesion till healed status is demonstrated by contrast MRI or PET scan. And this is one example. This is a classical radiologically diagnosed cervical spine lesion. And this is the classical MRI finding. So I'll just, due to paucity of time, they will not describe the finding again. And this is the radiological healing. You could see that radiological healing has started appearing. And this is on MRI also in T1 weighted. It has, the body has become brightened, so fat necrosis has taken place. And at 10 months, PET scan demonstrated no activity, and the ATT was stopped in this particular patient in that series at 10 months time. So the regimen is 4 drugs for 2 months, 3 drugs for 10 months, daily doses. Closely monitoring is to be done for development or progression of neural deficit, and all those patients who require surgical intervention to be intervened. Total duration 12 months, extendable up to 18 months on case-to-case basis if you are not able to demonstrate attainment of healed status. Now children, the same drugs is to be given. The only thing is that you have to calculate ATT volume of the drug based on the weight of the child. Every child has to be, ATT has to be customized. And another important thing, that these children, once they are put on ATT, they gain weight. So that on every visit, by at least 2 months, every 2 months, you have to ensure that your ATT doses are adjusted. Now the last in drug therapy is a failure of drug therapy. And this is all because of development of suspicion of a drug resistance, which I'll just talk a minute later. Now with neural complication, early onset or paraplegia with the active disease, and the late onset paraplegia with healed disease. Now in early onset, it is the compression which is causing the paraplegia by disease, mechanical compression or instability, while in late onset paraplegia, it is not the activity of disease, rather it is a long-term changes into the spinal cord as a result of sequelae of severe kyphosis. Now surgical treatment, it is very difficult to talk about in detail, but indications are when you are operating for a neural deficit, or you are operating for instability, impending neurological deficit due to a panvertebral disease where the body and the posterior complex simultaneously disease, or a long segment disease where after decompression you have to span the graft is need to be spanned by instrumentation, or when a deformity correction is to be contemplated in active disease, particularly in children where we have a severe kyphotic deformity and where you are suspecting a drug resistance. You want to procure tissue to submit for a demonstration of resistance, and that is why presumptive drug resistance is an indication of surgery. And late onset paraplegia, because here the sequelae of kyphotic deformity, if you don't intervene, then spinal cord further will be damaged, and that neural deficit will be non-recoverable. Now instrumentation, yes, there was some controversy, but now instrumentation indications have been defined, that in a panvertebral lesion where body as well as posterior complex is disease, you have to instrument the spine. Large post-debridement defect, if you have decompressed this kind of a long segment, then graft need to be protected. Or a severe kyphotic deformity is corrected, because there you have to do a posterior column shortening as well, then it has to be instrumented. And TB of junctional area, because it has a severe repercussion on the progression of kyphotic deformity and development of neural deficit, and hence it is advisable to instrument the junctional area lesions. Instrumentation type could be of any kind, and that all depends on availability, that depends on the number of vertebral body, that depends whether what is the bone health, where say for example, here we did the pedicle system, while doing the pedicle screw on the upper part, the pus started coming out, so we modified into the upper part is just taken as a hard shell, and here the whole hard shell was given. So all instrumentation of all works well if correct principle of instrumentation is used. And here again you could see such a long segment disease, and here this you could see the destruction of so many number of vertebral body, so spanning some the posterior complex of some vertebrae, leaving some, and then again. So you have to plan the instrumentation depending on the type of case. Spinal deformity is very important. As I said, if the spinal deformity heals with 60 degree or more, there are more chances of late onset paraplegia. So it is easier to correct spinal deformity in active disease. You need to identify, you need to see the natural history of that particular kyphotic, whether it is going to be progressive or not, and then you take for deformity correction. And the principle are, whenever a patient is taken for deformity correction, you have to do anterior corpectomy, you have to do a posterior column shortening, and when both are done, instrument the spine, you have to do anterior gap grafting and the posterior fusion. So this all have to be done simultaneously. This is a difficult surgery. This is a complicated surgery, labor intensive, and it has to be done by only those who are well trained and who are regularly doing it.
Dr. Anil, we are exceeding time. We are very short.
I'll just finish in a minute.
Yeah.
I think drug resistance again. We have, what I mean by drug resistance. Now this was TB lesion, and at 9 months the lesion is the same. So there has to be something wrong with this patient, and that is why these are presumptive drug resistance cases. And here line of action is that take tissue, submit for histology for diagnosis, take smear, genotypic analysis, and gene experts, LPA, and a culture to prove drug resistance. I think I will not talk about the drug treatment of drug resistance, because it itself is a big lecture, but there are certain principles that you have to read, and I'll just recommend one of my article on this, and you read that, and that these are the various definition of drug resistance. And these are more toxic drugs. They are used in higher number. You have to use certain those drugs which are less potent, but then you have to use, because that's the only way you are going to eliminate, cure the patient from tuberculosis. Now, these are the various regimen being prescribed for 1 drug resistance, 2 drug resistance, but then prevention of drug resistance is the key, and that's what you can do by monitoring the first instance when you are treating, monitor the drug resistance, drug treatment properly, so that there is no drug compliance is good at first instance. Well, in children, deformity progresses very rapidly because these are soft cartilaginous bone, and hence they have to be diagnosed early. Otherwise, in 2 to 3 months' time, they can develop such a grotesque deformity. And that is why, and this deformity progresses with growth, because even after tuberculosis healed status is achieved, this deformity is likely to progress with the growth. And that is why, and these are the severe kyphotic deformity, which may end up, some of them, with the late onset paraplegia, and they need to be corrected at first at the wet stage when the lesion is active. Otherwise, these kind of a severe deformity, you are going to end up in a severe kyphotic deformity. Had it been treated at this stage when the lesion is active, this surgery would have been simpler. But with the late onset or with the healed kyphotic deformity, it becomes a difficult proposition. So friends, so we have to suspect early and treat early. Diagnosis must be ascertained at all costs. Treat adequately till healed status is achieved. Surgery, individualized indication. Drug resistance is a menace to be prevented, and children be little aggressive to make diagnosis and treat. I think these are the 3 suggested reading. This is again a article in JBJS British, and this is an American. If anyone wants PDF, because this has not come as yet, so anyone wants PDF, I can, any students can take from the students of UCMS, or else I can put on the DOA website. And this is again a drug resistant article, which is a very comprehensive article to give all insight onto the postgraduates. And in this book, there are 200 questions for the postgraduates, and the questions have been answered as if it's being put to the postgraduate student, and what you face in your clinical practice while treating a patient. So these 200 to 300 questions have been answered with the reference. So these are the suggested reading. Thank you very much indeed for patience.
Thank you, Dr. Anil Jain. Doctor, hello, everyone there? Dr. Ankur, are you there?
Yeah, Dr. Manish.
Yeah, please go ahead with your presentation, because we'll take questions later on. We have Dr. Vineet will take questions later on. We don't have time. We have already consumed 3 hours.
Okay. Sure.
Dr. Ankur, please.
How can I unshare?
Sir,
okay.
Stop sharing just.
Yeah.
On the top.
Dr. Ankur, I want that you give a very crisp and just give the message, because we are falling short of time. So make it short.
I absolutely understand. So, can you see my screen now?
Yes, sir. You can go ahead, sir.
Can I go ahead? All right. So my job was here to, go through the management guidelines for thoracolumbar fractures. And since I think we are, reaching at 10 o'clock, what I'm going to do is, just skip through many of the slides and just talk about the basic principles about here. One point about thoracolumbar junction, why we are talking about these fractures is because this particular anatomical area is very typical in terms of it's a junction between a rigid kyphotic spine, which is supported by the ribs, with the mobile lumbar spine. And whenever there is a trauma or whenever there is a big force acting in this junction, it is likely to cause fractures or dislocation at this junction. And that is why this anatomy is very important. Dr. Sudhir and Dr. Sural have gone through the neurological examination and also through the concept of spinal shocks. I'm not going to repeat, but at the same time, it is very important for the PGs to understand that the concept of complete and incomplete injuries. A complete spinal cord injury is something wherein there is a total lack of sensory and motor function below the level of injury, and there is no perianal sensation or voluntary anal contracture. Whereas in an incomplete injury, there may be some preservation. Why it is important to understand this concept of a complete and incomplete injury? Because it does have a huge bearing on how you are going to manage these fractures, what is your attitude going to be. And also talking about the sacral sparing, which Dr. Sudhir has well covered about spinal shock. So you must understand that before you label a patient as a complete spinal cord injury, you must make sure that he is out of spinal shock, because that will make a huge difference in his prognosis and also in probably the surgical scenario. The classification of thoracolumbar fractures has been being evolving over so many years. In the last 60, 70 years, the classification is still evolving. And why do we classify these fractures? As we know, is basically to communicate with each other. The classification gives us the treatment guidelines, and it also tells us about the prognostication of an injury. And for thoracolumbar burst fractures, actually, these classification systems are actually the key to management principles. So for us orthopedic surgeons, these classifications have kept evolving right from the time of Boller, when he introduced the concept of mechanism, to the concept of stability. And over the years, we have come up with a number of classification, like the Nicol classification, or 2-column classification, or 3-column classification. And finally, somewhere in 1983, we started getting hold and, we started getting an understanding of what spine is about when the 3-column concept was introduced by Dennis et al., who divided the vertebral column into 3 parts. The anterior 2/3 was the anterior 2/3 of the vertebral body, along with ALL was the anterior column. The posterior 1/3 of the body, along with the PLL, was the middle column, and the post structures, everything behind, were the posterior column. Now, I am stressing on this part is because our management principles will depend upon the involvement of these 3 columns in different fracture patterns. So if we can identify these columns, we can identify injuries, how many columns are getting involved. They would guide us what we want to do with this, with our patient. So we have discussed that neurology is one of the most important factors to make a decision. Column involvement or the morphology of the fracture is the second most important factor in deciding. McAfee also came up with a classification. Now, the third factor which we have been talking about, the load sharing classification, was introduced somewhere in '94. This is the time when the CT and MRIs were gaining popularity all over the world. And what this classification looked like, it was basically, it came in the era of the short segment fixations, which when they started failing. So what are short segment fixations? These were fixations wherein a screw was put one level above the fracture level and one level below the fracture level. And they started realizing that some of the cases were doing very well with a short segment, some of the cases were not. So they started looking at what cases were doing good, and they realized that with this classification, which he introduced, wherein he divided the fractures into three parts depending upon combination of the fracture displacement, and kyphosis correction. And he realized that according to his scale, if the score was above 6, then these patients were likely to fail with a short segment posterior construct. So this was the load sharing classification, which came in 1993. The AO guys came up with their classification. We know how comprehensive these AO classifications have been. But the problem with the AO classification was that it could not be applied universally. It was too complicated, too difficult to remember. And there were a lot of studies which came in, which said, like this study by Honor et al., which said that there was a very poor inter-observer reliability. So now this brings me to the last two classifications. So you can sort of, if you think the previous slides have gone quickly and too fast, that's okay. You need to now concentrate on what I'm going to present, because these are the two classification systems now which are most in vogue, and these are the ones which really guide you in deciding what sort of management you want to do for a fracture. So this classification was introduced by Vaccaro et al. It's quite popular, which is called as TLIX, which was in 2005. And it looked at three factors. One, which we talked about, the injury morphology, how many columns, what type of fracture it is. Second, integrity of PLC. What is PLC? PLC is the posterior ligamentous complex. The posterior ligamentous complex is made up of the posterior supraspinous ligaments, the interspinous ligaments, and also the facetal capsules and the ligamentum flavum. So the integrity of PLC is the second most important factor. The third is, as we were discussing, neurological status. So how did he go about this classification, and how does it help us in management? So they looked at morphology, and they looked at compression fractures, which was simply end plate fractures. They gave them a score of 1. Then they classified burst fractures, which were not only end plate fractures, but were associated with the disruption of the middle column and were called as the burst fractures, wherein there is a classically there is a splaying of the interpedicular distance. The third type of morphology was translational injuries, as we see in fracture dislocation, which were given 3 points. And then fourth point was the distraction injuries, wherein the posterior ligaments may have torn in distraction, and this distraction injury may have come into the middle as well as the anterior column. These points were given according to the instability this injury morphology is creating. So a burst fracture would look like this. With on an X-ray, there seems to be a superior and inferior end plate fracture, along with retropulsion of the posterior fragment of the vertebra, along with an interpedicular distance widening. If you look at the CT scans, you can see that there is a break in the vertebral body. There is a vertical laminar fracture, which is usually associated with it. So these were classified as the burst fractures. The other type of fractures were the translation or facetal dislocations, wherein the vertebral body alignment has changed and the facets have jumped or broken. And the distraction injuries were when there was interspinous widening, interspinous fractures or pars fractures on the posterior side, which means that there was the axis of rotation was in the front of the spinal column, and the spinal column was opening from behind, which were called as the distraction injuries. The injury of posterior ligamentous complex was given different scores. If the PLC complex was intact, it was given 0. Suspected injury, 2 points, and then definitely injured posterior ligamentous complex was given 3 points. The neurological status, again intact, because intact neurology was given 0 point. A complete injury was given 2 points, whereas an incomplete injury was given 3 points, because it is more important and more urgent to operate in people with incomplete injuries. So this was the table, and they gave us the idea that if the score is between 0 to 3, a non-surgical option may be given, whereas the score is above 4, a surgical option can be given. Which means that if you have a patient with intact neurology, which means score 0, with an intact PLC, which means score 0, but a burst fracture, which means score 2, you can conserve this patient. But at the same time, if you have no injury in the morphology, which means score 0, but the PLC integrity is gone, which is score 3, and the neurological status is incomplete, which is score 3, then you have to operate that patient. So it gives us a lot of idea, although it does leave some gray zones. And because there were some gray zones and still the principles were not clear, the AO system, and this is the second classification which we must remember, this system came up with, has come up very recently, which is very comprehensive, and it is involving all the factors, like it involves the morphology, the clinical factors, and the inter-observer and intra-observer reliability with this is very, very good. This is the classification system which has been given by the AO. Now it looks very complicated, but if you divide it simply, it's very easy. So if we hide this area, these are the type A fractures, which you start from the above. These A0 is minor fractures, A1 is end plate fractures, A2 is both end plate fractures, A3 is an end plate fracture with middle column, and A4 is a both end plate fractures with middle column. So this is the progression from a minor injury to a severe injury, and these are type A's. As you go to type B, these are PLC injuries actually. So when you look at B1, it's a pure osseous injury, wherein the injury is happening right from the front, right up to the back, and the posterior column is failing in distraction. B2 injuries are soft with bony injury, and B3 injuries are actually anterior hyperextension injuries. The last part of the classification is translation injuries. So any fracture dislocations, shear injuries, lateral translations are coming under this. The beauty of this classification is that as you go from A to B to C, the instability and the severity of the injury increases. So you know, when you say AO type C, you know you are talking about a bad injury. When you say AO type A, it's a lesser severe injury. Similarly, when you go from A0 to A4, you know that A0 is a minor injury, but A4 is a severe injury. So it's very easy to communicate, and the treatment also depends upon the classification. Then there are factors which neurological factors which gives different meaning to different neurology. Then there are modifiers about whether a tension band is broken, not broken. So it gives a lot of description and helps us in making a decision. This is the algorithm which they give for now going through the classification and deciding what you want to do. So you have to ask just 4 basic questions. Do I see any disruption in the alignment? If you don't see any disruption in the alignment, go to the next step. If you see a disruption, it's a type C. The second is, do I see a distraction in the posterior tension band? If there is a distraction, the tension band is broken, it's a type B. If it is not broken, then you go on to the next type, which is the type A. In type A, you see if there is a vertebral body fracture or not. And depending upon whether it is only end plate fracture or middle column fracture, you can divide them into compression fractures, split fractures, incomplete or complete burst fractures. So basically going by the principles, all stable fractures.
Dr. Ankur, please summarize.
Yes, this is the last 2-3 slides, sir. Okay. So all stable fractures, which are the compression fractures and stable fractures, can be treated conservatively. However, unstable fractures, which are usually AO type B or C, or flexion distraction injuries or translation and rotational injuries, they will usually require surgery. So basically we need to establish the stability part of the fracture. Stable fractures can be conserved, unstable fractures need to be operated. There are different decision-making factors as we discussed. How do you do a non-operative treatment? So if you want to conserve a patient, you can give him a short period of rest for 5 to 7 days. Then you can get standing x-rays at 15 days. And if these standing x-rays show that it is unstable, you go for surgery. If the standing x-rays are looking reasonably stable, you can brace them and continue these braces for 3 months. On the other hand, for surgical indications, anything which is type B and C, a loss of height of more than 50%, a kyphosis of more than 30-degree local kyphosis, or a canal narrowing of 50% requires surgery. The last thing about approach, majority of the fractures can be dealt from the posterior approach. There are certain fractures which are really bad with really bad combination and the fragments getting into the canal and occupying a significant amount of canal may need to be dealt with a combined anterior and posterior approach. But more or less the workhorse approach for these fractures is posterior approach. The last slide is about the length of the construct, and with this slide I'll end the presentation. So there has been a lot of talk about how much instrumentation needs to be done, what levels need to be instrumented. So classically, we have been talking about short segment fractures, short segment constructs, wherein the screw is put one level above and one level below the fractures. But we know there are high failure rates with it in certain classification types. So the concept of long construct came, wherein people started putting two level screws up above and 2 level screws below. The failure rate is down with these constructs, but the problem is they are too long. They cause a lot of stiffness and sometimes back pain to the patients. So now what is gaining popularity is the fracture segment construct, wherein we try to negotiate pedicle screws into the fractured vertebra itself and then put a level above and level below. So this gives us enough stability and at the same time doesn't compromise too many motion segments. So depending upon the neurology, depending upon the PLC injury, and depending upon the intactness of PLC, we can take a call what sort of surgery we want to do. I think I'll end up here. Yeah.
Thank you, Dr. Ankur. We'll take Dr. Abhay Nani's lecture now, and then we go in for questions if we have time. Thank you, Dr. Ankur, for a very nice presentation. Dr. Abhay Nani.
Thank you.
Dr. Abe, you are not audible.
Am I audible now?
Yeah, you are audible.
Yeah, thank you. I said dinner is over and it's time for desserts. But when this case comes to PG student in the exam, he or she is completely at sixes and sevens in trying to answer these questions. Most of us don't even know if it's a kyphosis or a scoliosis, and you'd rather have hope that you got a lumbar canal stenosis as your long case. But trust me that the symbol of orthopedics is a scoliotic tree, and orthopedos means straight child, so it refers to scoliosis. So I'm making my case to say that the good news is it's the easiest case. It's a great long case to have. It's a gold medal case if you ask me. The second good news is that I'm sharing this presentation with all of you on WhatsApp and all other places, so you can casually rummage through what I'm talking about. To get to the point, scoliosis has been defined by the Scoliosis Research Society as a lateral curvature of the spine of more than 10 degrees. And as surgeons, you will see scoliosis as this. So it's famously seen as the hunchback of Notre Dame. But in truth, it's actually a three-dimensional deformity. It's not a single plane curve, but it's actually a curve in three planes. One is what you see front on or on the coronal plane, which is a C-shaped curve. On the side view, you see a hypokyphosis. So unlike a common perception, it is actually a flat back or a reduction in kyphosis. So typically a scoliosis, which is an adolescent idiopathic scoliosis, the lordoscoliosis rather than a kyphoscoliosis, must remember that. And in fact, it is actually a rotational deformity. So all of you will do well to imagine a scoliosis as a stack of carom coins that have been twisted up in the middle, and that twisting has led to the spine, to bend over in multiple planes. How does this spine bend? So to clear this confusion, you should look at this diagram at the bottom right. Always remember the vertebral body shifts towards the convexity, and along with it pushes the rib out, and hence the rib hump and the rotation of the vertebral body is on the side of the convexity, while the spinous process points to the side of the concavity. How do you determine whether this is a true kyphosis or a true lordosis? Run your thumb along the spinous processes, and you'll see that the furrow is quite deep. The spinous processes don't pout out. Some definitions that you need to know: a structural curve versus a non-structural curve. A curve that is that has a lot of intrinsic changes, like the bone is rotated or the bone is wedged, or a curve that does not straighten up on bending is a structural curve, while the other is a non-structural curve. Another definition is major and minor curve. This is an English language definition. A curve that is larger is always the major curve, and the one that's smaller is always a minor curve. And hence, you guessed it right. If there are two equal curves, it's called a double major curve. What about compensatory curve? So when the child bends, there's another part of the back which is a flexible structure which tries to balance this bend, and that curve which is trying to balance the center of gravity, that's called the compensatory curve. A fractional curve is a curve which is only 1/4 a circle, while a full curve or a regular curve is one that's at least half the curve. These are quite colloquial definitions. This is important. What is decompensation? So a scoliosis that takes the head outside the line of gravity is a one that is a decompensated scoliosis. So if you drop a plumb line, you need to carry a plumb line to your examination room when you go for the exams. It's just a thread with a weight hanging at the bottom to aid gravity. So if you put the top of the thread on the vertebra prominence and drop the plumb line down, if it's beyond the natal cleft by more than a couple of centimeters, this is a decompensated curve, which is bad news because gravity alone will increase this curve. Typically, AIS increases with growth. But if it's a decompensated curve where the center of gravity is shifted, even after growth stops, this will keep on progressing. Quickly to tell you about what these confusing names are, because you will be asked this in the exam. Strategic vertebrae are vertebrae that actually make the deformity. So when you look at the Indian cricket team, there's a whole bunch of guys there, but your eyes only look for these big guys, right? So similarly, they're big guys in a curve, and these are the end vertebrae, apical vertebrae, stable vertebrae, and the neutral vertebra. So the end vertebra, this definition you must know, it is a maximally tilted vertebra on either end of the curve, as you can see in this pictorial. So each curve in a spine, every spine has 3 curves. So this spine has a curve on the top, a main curve here, and a curve at the bottom. So make a habit of looking at every spine divided into 3 parts, and you'll start seeing those 3 curves. So every curve has an upper and a lower end vertebra. The lower end vertebra of one curve could coincide with the upper end vertebra of the other curve. So in a spine, you could have a maximum of 6 end vertebrae and a minimum of 1, 2, 3, 4 end vertebrae. I hope that's clear. To identify end vertebrae, you look at which bone is most tilted. Like here, you can see the L1 seems to be most tilted. But if there's any doubt in your mind, draw lines that are along the end plate, and you will see that these lines diverge into the convexity of the curve. So if these lines turn parallel, it means that these two bones are equally tilted, which means the L1 would be the end vertebra. And in fact, if the lines converge towards the convexity of the curve in question, you've gone into the next curve. So in a situation like this, the L1 would be the lower end vertebra of the main thoracic curve. I hope that is very clear. When you do bending x-rays, these end vertebrae change. However, end vertebra for a given curve is like the name. Your name will not change whether you're in Bombay, Delhi, or North America. Similarly, once end vertebrae are defined on a standing AP x-ray, you cannot change that name. And hence, end vertebrae on a bending x-ray are called intermediate vertebrae. These are important to know because these are the bones between which the segment of the scoliosis is stiff. And if and when you're doing surgery for this patient, you have to work harder on this segment. What is the apical vertebra? The apex of the curve is the apical vertebra. This is invariably the most rotated, but curiously, the most horizontal vertebra, as against the end vertebrae, which are the most tilted vertebrae. Sometimes the end vertebrae could, the apical vertebra could actually be a disc. So how do you know which is the apical vertebra? You draw a line that is perpendicular to the central, draw a central sacral vertebral line, vertical line, which is a vertical drawn from the middle of the sacrum, and draw a tangent to it along the curve. And where the tangent cuts the curve is the apex. So in this particular case, it's cutting the curve at a disc rather than a bone. So in this case, the apex of this scoliosis is actually a disc and not the bone, which means that this scoliosis has two apical vertebrae. What is a neutral vertebra? End vertebra alludes to tilt. Apical vertebra alludes to apex. Neutral vertebra alludes to rotation. So a rotation of the bone is looked upon as a face of an owl. So when you look at an owl, it's got two eyes, which are the pedicles, and a nose, which is a spinous process. So when the owl is looking at you in the eye, the nose is in the middle and the eyes are equally spaced. The minute the owl starts to turn his face around, one eye looks bigger and the other eye looks smaller, and the spinous process starts looking bigger and bigger. So rotation is been defined by Moe based on the this presence of the spinous process vis-a-vis the pedicles. What about the stable zone? You may be asked, this is an engineering concept. The zone in which the line of gravity falls. So if you draw two vertical lines from the L5S1 junction, that is a stable zone. It's important if and when you do an operation to start and finish your surgery in this stable zone, else your tower will be erected outside the line of gravity and it will tend to fall off on one side. Stable vertebra is the vertebra that is best bisected by the mid-sacral line. Again, this is self-explanatory, and your lower instrumented vertebra should safely be the stable vertebra. So if you stop your surgery here, your entire tower will be erected obliquely and it will fall off. So end your fusion at the stable zone. If you do not end at the stable zone, as you can see in the diagram, the entire fusion will fall off on one side. So you should know your strategic vertebrae, because if you reach the point of an X-ray in your exam, which means you're probably getting a gold medal, you will be asked this, and this is Pakka gold, right? Now, this is the key part for a postgraduate, history taking in an AIS. The specific questions that you ask in an AIS case is age, because younger the child, the more likely he's going to progress. Growth spurt, so when did the child achieve menarche or puberty? Birth history, was there a difficult labor or anything specific? Brothers and sisters who are suffering from a similar condition. When was the curve first noticed? What's the progression of the curve? Has it been rapid or has it been slow? Remember, chief complaints and the onset, duration, and progress of chief complaints. If you follow this mantra, all your cases can be dealt with. So what complaints do you ask? So a typical case of an AIS will have none of these complaints. So if your child complains of any of these, of course, back pain, everyone complains of, but anything else like weakness, numbness, significant pain, dysfunction, breathlessness, it is not AIS, remember. AIS patients only complain of cosmetic deformity. Now, that is not enough. It's not good enough to say my patient has presented to me with a cosmetic deformity. You have to specifically ask what part of the deformity bothers the patient. And when you give your final diagnosis, this should be a part of your final diagnosis. So when you look at the patient in the clinic, you look at the neck tilt. Again, this is a very useful slide. And if you can just describe all this to your examiner, rest assured he's not going to take you any further and you're going to be a pass. right? So neck tilt, trapezius fullness, shoulder height, chest deformity from the front and from the back, arm trunk distance, truncal shift, flank crease, pelvic tilt, limb length discrepancy and attitude, and neurology. If you can allude to all these points in your final diagnosis, you're mostly sorted. And these are the specific areas that you want to look for. You always examine a child of scoliosis in the sitting, standing, and lying down position, and you examine the gait. It's important because if a scoliosis disappears on sitting, it means this scoliosis is secondary to a limb length discrepancy or infrapelvic pathology. If the scoliosis retains itself on standing and sitting but goes away on lying down, it's because of a painful stimulus, which means that it's a spasmodic scoliosis. So it's important to examine these. You examine gait because hip and knee pathologies are visible in a gait when the child starts to walk. So I hope this is amply clear to everyone. When you look at a rib hump, the method to identify the rib hump is the 2 textbook method, where you make the child bend at about 90 degrees and look at him tangentially, look at her tangentially, put 2 textbooks tangentially on top and see the distance between these two. But today on your phones, there are gyrometers available, and there's a Scoli Angle Pro app, which you can use to actually calculate the angle. Of course, examine the spine range of motion and everything that your fantastic mentors have told you in the initial lectures. Which are the curves that are likely to progress? So you will be asked, what are the red flags in a scoliosis? A younger patient, a patient with a reserve sign of 0 to 2, a male patient, sorry, this says female, it's a male patient, a patient who has a family history, a Cobb angle that's higher, a rotation that's more, and double major curves are known to progress faster. What about X-rays? They will ask you, it has to be a 3-foot standing film, a 36-inch film, which is to be taken from 3 feet away. Don't miss the lateral film. So it should be an AP standing film. The most important, second most important is a lateral film. When you look at the X-ray, you want to look at the end vertebrae. You want to calculate the Cobb angle. That's the angle between the end vertebrae. And you got to look at the riser sign, and you got to look at the rotation of your end vertebrae and your apical vertebrae. And if possible, describe your stable zone, and that should do the trick. The next X-ray that you ask for, so AP standing, lateral standing, and then supine bending X-rays. Remember, these are not standing bending X-rays. These are supine bending X-rays, which tell you about the flexibility of all 3 curves, not just the main curve that you see, but even the lower curve, which is important in planning. In case on an X-ray, you find that the rib is actually abutting against the ilium, you do what is called a traction film. For example, in this X-ray, you find there's a lot of space between the rib and the ilium. So here, a bending film will give you a true sense of the flexibility of the curve. But if the rib is hitching against the ilium, you do what is called a traction film, and that's more common in your kyphotic neuromuscular scoliosis, and that will tell you how the correction is. Look for pelvic obliquity, make the child lie down and examine the hip. So in your final diagnosis, all these should be covered. The cause of scoliosis, which side is the main curve convex to? Is it a single or double major? Is it compensated or not compensated? What are the likely end vertebrae? What's the likely Cobb angle? Is it kyphosis or lordosis? Is it a big or a small rib hump? Is it rigid or flexible according to you? What is the age and growth potential of the child? What is the pelvic obliquity? And point number 12, why has the child come to you? What is his complaint? What is her complaint actually? And in any of these are the classic red flags where you would suspect that this is not an idiopathic scoliosis. A younger child, a left convex curve, a male child, rapid progression in the scoliosis, skin signs, neurology, pain, or a family history. All these would make you suspect this is not idiopathic scoliosis and get an MRI scan done in all these cases. Of course, when you classify scoliosis, I'm going to skim through this because this is all there in your books. There is dystrophic scoliosis, which is typically neurofibroma. There's degenerative scoliosis, but you got to know the King's classification, and I have a simple trick to remember the King's classification. Number 1 and number 2, type 1, type 2 are T and L double curves. Type 1, T is small, L is big. Type 2, T is big, L is small. Type 3 and type 4 are C-shaped curves. In type 3, L3 is in the midline. In type 4, L3 is outside the midline. And 5 is a double thoracic curve. So it's quite easy to remember the King's classification. It's much more difficult to remember the Lenke classification. And I beg you not to try to remember this classification. You'll forget everything else. So just remember the principles that Lenke classification teaches. It tells you that every curve is made up of 3 parts. So even though one curve is staring at you in the face, look above and look below before you decide what kind of a curve this is. So divide every spine into 3 parts. The second thing it tells you is look at the sagittal profile of every spine. Don't just be happy with the with the lumbar, with the AP view. And the third thing it tells you is that identify and subclassify your lumbar curve, because that's what's going to tell you how low you need to go when you do surgery. And quickly, to come to management principles of scoliosis, the idea of surgery is fusion, and the surgical limit is most cases after a 40-degree angle of Cobb's are considered surgical, but the child should want the operation. There's no need for the operation, there's a want. So if someone comes saying, I'm feeling happy with myself, you don't need to offer surgery. It's a purely cosmetic surgery in adolescent idiopathic scoliosis. Because the surgery alludes to correcting and fusing the spine, you're halting growth, and hence you want to delay surgery as much as possible till you can get maximum growth in height. The ideal age for surgery is, of course, after growth is achieved, which is about 2 years after meniarchy. But the closer you can get to this is better. 40 degrees is the cutoff for surgery, but this is not a rule that's cast in stone. There are variables. A 30-degree curve, which is decompensated, may still become surgical. They will not typically ask you indications for surgery. All that you need to know is that indication of surgery is if the child is unhappy, which is cosmesis. You don't get respiratory problems in idiopathic scoliosis. You get respiratory problems in neurofibroma, in high-grade syndromic scoliosis, and in cases which have deep kyphosis. The surgery is done by posterior instrumented correction. So you put anchors, and the methods of correction are translation. So you put anchors in the spine, screws in the spine, and pull the spine to a straight rod. As barbaric as it may sound, it works. The other is the cantilever technique, when you push the rod against the spine and correct the rod using anchors. So that's the cantilever technique. And the third is the derotation maneuver, where you put a bent rod and then twist it around in a way that the spine corrects. So a bent rod is then twisted to make it look straight, and that makes the spine straight and makes the spine nicely curved on the side view. And that's the kind of correction you get at the end of the day. So finally, to sum up, when you make your diagnosis, you say which type of a curve it is: left, right, convex, thoracolumbar, lumbar. You say whether it's compensated or decompensated. You ideally talk of the end and neutral vertebrae. You talk of whether it's kyphotic or lordotic. You talk of rotation and rib hump. You talk of flexibility to the in your final diagnosis. You talk of the remaining growth potential. Sum up the pelvis and the hips, and finally make your diagnosis with all these 11 points. The point number 12 being, and sir, this patient has come to me with the chief complaint of a rib hump that irritates the patient. So my take-home message is, identify your scoliosis well, give your diagnosis in the 12 parts, and get a gold medal. Thank you.
Thank you, Dr. Abhay. We have only 5 minutes. Thank you for such a good, nice lecture. We have 5 minutes. I will take few questions from the audience and then we wrap up. Dr. Shankaracharya, are you there? Dr. Shankar? Dr. Shankar? Okay. Dr. Abhay?
Yes.
There is a question for you. How to check for spinal balance? First question, and second is spinal flexibility, 3-point bending concept.
So spinal balance is by the plumb line. You take a rope with a weight at the bottom, put the rope against the vertebra prominence and let it drop down. And if it falls within the natal cleft, the gluteal cleft, within 2 centimeters of that, it's a balanced spine. If it's going off, it's an unbalanced spine. That is in the AP view on the, on an AP, and on the lateral, you drop the plumb line from the tragus. It should fall within the center of the trochanters. The second question was?
A 3-point bending concept.
3-point bending. So sometimes when you do a bending X-ray, your ribs come in the way of, and the ilium gets abutted, and you can't then bend any further. So you get false or inadequate information. In such a situation, if you can put a fulcrum at the top of the C and put a fulcrum and then bend over the fulcrum, you get a much better bending X-ray, and that's called a fulcrum bending X-ray, done in specific cases where there's an abutment of the iliocostal junction.
Okay. Dr. Shankaracharya.
Yes, sir.
Shankar, can you tell about failed back syndrome?
Well, it's you have to have another seminar on spine, because
no, just short. They want you are not touched about the failed back, so just briefly you can tell them.
Well, I think the terminology of failed back should not be used. Number one, I think it should be called revision back surgery. I think failed back is not the terminology to be used, because after a surgery which has not worked for a patient, there are many options there are many reasons why this should happen. One is identifiable cause and one is unidentifiable cause. When we do spine surgery, a lot of causes of spine surgery are linked with psychosomatic illness behavior and other compensation behavior. So if a patient's surgery fails, first what we do is we need to investigate and assess the history all over again and go through it all over again to see and investigate him or her with again set of x-rays, MRI, to see if we can find an identifiable cause of why this surgery failed. And about 60% of cases, you will have an identifiable cause. And if you rectify that cause, it will work. So it's just like a femur non-unions. You don't call femur failed. You call surgery needs to be revised because the surgery didn't work. But there will be about 30-40% of patients where you will not find an identifiable cause. And in those cases, you will have to try for all conservative methods first. And failing that, then you may use, there are special methods called spinal cord stimulator and things like that, where you can confuse the brain, which is the pain receiving source, from where the pain came. So we do use spinal cord stimulators in some situations. And that is basically in concise about failed back.
But I want to add a 2-bit. Failed back happens in 3 situations: wrong diagnosis, wrong patient, and wrong surgery.
Yes.
So if your diagnosis is incorrect, you get a wrong result. If your patient choice is incorrect, and if your surgery is incorrect.
Very true, very true. So I thank all faculty, and you are great because you sat for, we took 3.5 hours. So already have we passed. So I request Dr. Sharad and Dr. Hitesh to do the closing remarks. Dr. Sharad?
Yeah. I must congratulate the whole team, the whole eminent faculty. They have given a very excellent disposition. I think we as well as the audience will never be satisfied, but things have gone for too long and have to be stopped at some level, some stage. I think Dr. Manish Dhawan, we should have another seminar on spine sometime in the future.
No, we will have only case based. Normal, like we will have a student who will take a history, he will examine, totally recorded. We will not have any lectures that time. So for hip and spine, we will have a proper this thing.
Right.
And Dr. Hitesh, are you there?
Yeah, I would like to thank the faculty. And each and every lecture was very meticulous and comprehensive. And it was a very nice listening to each and every lecture.
So all these lectures will be available on the YouTube, and we'll send you the recording. And I thank the whole faculty. Dr. Kamran, you are very nice. You are the opening batsman, but you stayed
thank you, sir.
3.5 hours. Dr. Sudhir Kapoor, Dr. Sural, Dr. Shankaracharya, Dr. Vineet was also involved.
Especially thank Abhay, because Abhay has been doing webinars since morning, and I have for his last 25 days. He's always on the net. I don't know how he has this patience. Amazing.
He is not doing anything else other than the webinar.
I'm not seeing any COVID patients.
No, webinars and singing also. He posts every day.
Exactly, sir.
Okay.
His guitar is still visible.
Yeah. And finally, I thank Dr. Shamsul Huda and Dr. Ravi Chauhan for providing the technical support. And thank you, everyone. Dr. Ankur, thank you.
Thank you, everybody.
Take care.
Thank you, sir.
Thank you so much.
Thank you, sir.
Thank you.
Thanks for permission and stopping live stream, sir.
Yeah.
हितेश का वीडियो कहाँ चला गया?